Can you see the slides? Participants, please, in the chat box, if you see the slides. You see the slides, please answer in the chat box, please, that it's visible to you. إذا شايفين يا إخوان السلايدات بس أعطوني الإجابة بالشات بوكس لو سمحتوا بالله. إذا واضحة السلايدات. دقيقة. I think the chat box is not open yet. 1 minute. Admin, please help with the chat box because it doesn't open before we start. We are working with chat box to work. Please give us some time. Yes, I think I solved it. Yes, the chat box is working now يا اخوان. واضحة سلايدات يا اخوان في الشات بوكس. دكتور رانيا روبش, are you available? Thank you everybody. Sorry for the delay. Dr. Rania, if you are available, you can start. Otherwise, I will start myself. You can send me a direct chat. Please check your chat box, Dr. Rania. Okay. If Dr. Rania not available, I'm going to start. Dr. Rania, are you available? I can see your name on the participant screen. Okay, I think I'm going to start. Then we will, I think the other speakers will follow, maybe for the time, the difference. Our speech today is about telemedicine and telesurgery in cancer care patient. As you know, it was difficult time during COVID-19 to handle patients with cancer, how to handle them, especially those patients who are on cycles and they will require some intervention like surgery or radiotherapy. It was a challenging time. One report has been, an international review has been done last year by Professor Santoro from Italy and Dr. Gallium from United States, and they reported that there was a delay in the treatment during COVID-19. And for that reason, the telemedicine and telesurgery was quite essential, although it doesn't replace surgery, but at least we have to know that there are some elements that telemedicine and telesurgery would be able to help patients. Moreover, access to quality of cancer care remains limited in rural and remote areas, and the supportive measures also are quite essential, which has the potential to enhance access to cancer care and to improve education and training. Tele-oncology is the best used bioconsistent and long-term application. One of the most common uses of telemedicine is for converting virtual tumor board, which is a physician at a remote location present patient cases as simple group. And I believe there are many examples of this, that even in Saudi Arabia, many surgical oncologists and surgeons, they do their own virtual meeting online till this moment. It has been accepted that the barrier typically through the telemedicine is acceptable. And in both sides, I think both of them understand the limitations. But from the other perspective, it was quite essential and quite important that those patients would be able to evaluate and to be evaluated and to be checked by physicians from the other side. The business case for tele-oncology depends on certain criteria. And it has been demonstrated that to break even financially, the service had to save at least 5 hours of physician travel time per month. But from other perspective, it is wasting physicians' time. As we listened yesterday to our meeting, it has been mentioned that getting the patient in the clinic will take something like 30 minutes from your time. But to see the patient through the telemedicine, it will take extra time because you have to prepare the patient, before you see the patient, and you have to do your orders and recommendations after seeing the patient, which means that you will expend more and more time. Another study, the University of Kansas Medical Center, showed the cost associated with delivering cancer care by video conference dropped from 812 per visit in 1995 to up to 251 in 2005, and now less than 332 cost of in-person visit. The threshold for economic viability was reached when more than 200 patients per year were seen. Several studies have demonstrated that effective physician-patient communication was experienced, and the new technological development in telecommunication have been impacted in the surgical practice. We have to know that telesurgery nowadays are taking a major part in the surgical departments and in the medical departments, and also in communication and education. So we have to consider this in our planning and curriculum planning, either for education or for the patient follow-up. One important part is that those patients, like patients who are in home health care, would be able to be evaluated and checked through telemedicine. So we have different types of telecommunication, including surgical procedure, telemonitoring, or telesurgery, or teleconsultation. All of these are parts of the telecommunication or telemedicine or telesurgery. It has been reported some difficulties in the use of telemedicine, which include the integration of the service into daily routine life, because you must prepare the patient from the other side, not at your side, which means that it will take some time to teach the patient how to utilize the technology. So why tele-oncology? Tele-oncology because patients sometimes wouldn't be able to visit the clinic for different reasons. Sometimes he's depressed, sometimes he's not willing to go to the clinic, sometimes he's feeling anxious going to the clinic. So tele-oncology may overcome such issues and would support the patient going to the virtual clinic. So the wider use of telemedicine and telesurgery include both legal and business concern, and also the bill of the cancer virtual care. How is it going to be done? We have to discuss this with the healthcare providers or the insurance company. The main principle was that implementing tele-oncology successfully require pragmatic selection of goals and the methods on the basis of needs and resources rather than politics and publicity. How to manage the need to have medical license in every state where a telemedicine practiced. So if we have some barriers for tele-oncology, that include legal parts, clinical part, and from the billing. From the clinical part, there are competition for patients, where some hospitals, they look for patients. So your patient will be lost to a different location, which means that you will lose the income that it's coming through its treatment. The cost-effective technology integration is also a significant issue about clinical part. And diverse clinical needs according to subspecialty, which means that the tele-oncology wouldn't be able to do that. So the diversity may be sometimes limited unless in your facility they have such variability. So the limited private insurance reimbursement will be also an issue, and defining sustainable business model also is a significant issue, because you have to discuss how to overcome these barriers. From the the policy and the legal part, distinct state requirement for insurer and the limited legal precedent to guide doctor and patient contractual issues with telemedicine. Central coordination to optimize integration of tele-oncology, individualized technology solutions. I think we have Dr. Rania Rupesh online now. She just joined us. So if Dr. Rania is available, I would appreciate joining us. I may. Okay, I think she's asking for 10 minutes to be prepared. I will continue, then I'll give the mic to her. Then I'll continue my presentation later on. So please, Dr. Rania, once you are ready, please send me a text message through the chat. So what are the key recommendations for tele-oncology implementation? A central coordination to optimize integration of technology, individualized technology solutions for clinical subspecialties, phased approach for implementation and funding. Community physicians integration according to financial and educational benchmark are quite significant issues. It was anticipated that tele-oncology will decrease the travel burden of stakeholders and improve access to cancer care. So, these have included in the use of robotic surgery, teleradiology consultation, video conference for smoking cessation. And overall, interest in telemedicine has continued to accelerate with decentralization and expansion of MD Anderson via regional care cancer centers and sister institutions, serving as a catalyst and focal point for this demand. A series of advanced technology demonstration by clinical faculty relevant to distance delivery of healthcare services has developed shared perspective and increased confidence in tele-oncology. It has been noted that the demand for e-health platform comes from both physicians and patients, since many patients at MD Anderson travel great distance to receive care in the institution. The physicians are keenly interested in identifying ways of monitoring and caring for this increasing patient volume that would improve upon traditional approach. So how to select the program and utilize the proper technology? For breast cancer care, telemedicine has improved the velocity of the critical care pathway via the use of teleradiology, telepathology, and tele-oncology consultations. This strategy has made possible the establishment of the same-day breast biopsy clinic, accomplishing on one day that formerly took for up to 7 days. Reimbursement of care has been addressed via parity legalization, and there is a Medicare and Arizona healthcare cost contaminant system coverage. It also has been demonstrated in the presentation titled Telecancer Virtual Care that Arizona has used telemedicine for consultation, clinical trial assessment, and education in cancer care. Lecture, tumor board, and chart rounds all have been utilized. Dr. Robert Williams presentation titled Telemedicine and the Ontario Telemedicine Network past, present, and future describe the efforts of the Ontario Telemedicine Network, which is one of the largest and most active telemedicine network in the world. Using innovative technology of Ontario Telemedicine Network, streamline the healthcare process to bring patients the care they need, where they need it, and an independent non-profit organization, OTN, is funded by the government of Ontario. And we have to remind you that yesterday we spoke about the latency period and the hepatic feedback of the equipments, and we agreed yesterday that the latency time, which is universally accepted, is something like 300 milliseconds. And also we agreed that the speed of the net and the communication and the latency period dropped down from 300 milliseconds up to less than 100 milliseconds. And that was a significant breakthrough in the communication part. OTN was established to develop and support telemedicine solutions and enhance access and quality of healthcare in Ontario and inspire adoption by healthcare providers, organizations, and the public. They currently have 4 channels of virtual care. And the top 5 therapeutic areas, which are mental health, telemedicine, primary care, oncology, and surgery, store forward asynchronous consult were supported in dermatology and ophthalmology, urgent and emergent virtual acute care. OTN supported 19,000 education events last year. Chronic disease management, also OTN supported patients in their home with cognitive failure. The program focused on coaching patients and better enabling them to self-manage their illnesses. Okay, Dr. Rania, once you are done, once you are ready, please go to the video and show yourself or raise your hand, the question and answer, so I'll be able to recognize your presence.
You need to give me an access to start the video, please.
Yes, this is Dr. Rania. Okay, 1 minute. Are you able to show yourself, Dr. Rania?
You have to give me an access to start my video. It says you cannot start
admin.
your video because host has stopped it.
Okay, 1 minute. Admin, please transfer to Dr. Rania, the host. Dr. Rania is the host now, please. Okay, you are the host, Dr. Rania. Go ahead.
Okay, that's perfect. This is better, much better.
Just 1 minute, Dr. Rania, just to present you to our colleagues. First of all, thank you very much for your presence in our activity, Dr. Rania. It's really a pleasure joining us in this event. Dr. Robesh Rania is Associate Professor in Internal Medicine and Nephrology and Dr. Rabish is working in Ohio Medical University, and he's the director of the medical research on internal medicine Cleveland Clinic. Dr. Rania is a well-known figure in the United States. He's basically a nephrologist, and he has very long experience. His CV is really impressive. He has a lot of publications and achievements and projects, and the list is long. It's a privilege to us, really, Dr. Rania, joining us today. And thank you very much for your presence, and the mic is yours.
Yeah, thank you. Good morning, everybody. I know it's good afternoon for you. It's a little bit early. Let me start sharing my screen. So let me know if you all can see my screen well.
Yes, it's clear. Go ahead.
Good. So basically, I was allowed to asked to talk about the telemedicine for pediatric nephrology perspective for COVID-19 and future practice and a workflow. As you know that the pediatric aspect of the nephrology and the COVID was so different that's compared to adult, because the data shows that there are very few cases in pediatrics. Like in the mean age was mainly 5 to 7. Incidence going from like 6 to 9%. This is our paper which came out, as compared to a spread was pretty universal. If you look around in Europe, in Italy, in Australia, and most of the vulnerable population was around 10 to 19 years, and younger patients were not affecting much with the real COVID. Actually, they were affected more with the phenomena which is known as MISC, which I'm going to describe. So this is our VPS data from North America for acute kidney injury COVID-19, which did show that the percentage was pretty low, around 6 to 7% with COVID-19 and AKI. And it was very well spread out among the age. And again, the vulnerable population was between 11 to 19 because they're more exposed, they are more outgoing, they will be more interacting with the people. And that was true across all over the world. Especially European data also reinforced the same spread. When you look for the COVID-19 in children's, what are the factors that was pushing them to go into this in the ICU, or what are the predictors of the poor outcomes was actually MISC with and PICU admissions, and admission to PICU was mainly the ARDS and AKI. And this was a very, very fascinating in the children population that progression to the severe disease was associated with the C-reactive protein, which is more than 80 milligram per liter, and D-timers. These are the two was shown in a meta-analysis outcome in our study, which showed that these are the factors that will lead you to the more severe disease. I'm not going to go into detail, but I think renal involvement in the COVID-19 is at every level. And there was a lot of saga between ACE use and the ACE receptor blockade, which we did a study in JAMA, and we showed there was no correlation between the ACE use and the progression of the ACE receptor blocker to the COVID-19. And it acts at every level. There has been a TMPRSS2 gene, which is co-expressed in the podocyte and the proximal convoluted tubules. So it's podocytopathy. And it also has shown that proteinuria and hematuria was very well involved. You get interstitial inflammation, you get collapsing glomerulopathy, and you also get the phenomena known as the cytokine storm because you're activating the myeloid cell with an activation. This is sequential point prevalence, 7 days to 25 years. You can see the role of this AKI COVID-19, how worse it was, and invasive respiratory support, vasoactive utilization, ECMO utilization, hospital stay were so significant in the children's mainly between 11 to 19 years as compared to other AKI registry, which was 26 versus 41. Severe AKI was 11 versus 19%. This is just a comparison in a children's regular AKI as compared to COVID with AKI. This is a paper which came out, which shows critical analysis of acute kidney injury in COVID-19, 24 studies, incidence of AKI was 30%, mortality was 2.5, MISC was around 75%. And pool incidents have shown that the patients and children, they overall do well as compared to adults. And same here, pool incidence in the pediatric studies shows that most of the time the kids, they do well, they do not need much RRT. As compared to the studies, adult, the pediatric population, the incidence was 26, but adult was actually lower, 15 with a severe AKI. Mortality was much higher in adult, 15% versus 1.9 in children. And utilization of KRT, which is a kidney replacement therapy, in adult was much higher, around 8% as compared to pediatrics. This is our data with the COVID-19 registry, which we have in January 2020 to June 2021. And again, the incidence was going up. This is a dashboard with the organ system involvement and organ support. Association of different categorical outcome among the AKI with VPS database shows that airway and respiratory incidence were pretty higher, kidney supports were lower, and the mortality was higher in children when they get AKI. And this is again association of the hospital stay, PIM, that is the probability of the death, and PIM3, which is more serious involvement, shows how it is different from stage 1 to stage 3. Then it came up the new MISC, which is a new syndrome affecting children's, and the children's have a very specific immune system as compared to adults. When you have an early interferon response, they clear the antibody and leukokines, chemokines much earlier as compared to the adult, and that's why they clean the infection much earlier than as compared to adult. As compared to adult, they do not have a very early IFN response. They have a slow viral clearance and they have more inflammation. This is a paper which came out in COVID, kidney involvement in multisystem syndrome in children's, and this was a pediatric nephrologist perspective. You may all know Khalid Al-Hassan at your place. He works with us very closely, just shows that this is a immune dysregulations, hyperimmune response need to MISC. And these are some of the treatment which is available. The big issue was that there was a big paradigm change during this COVID-19 to telemedicine. And telemedicine in pediatrics is not very well taken as compared to Canada and other places, because in North America, especially in the US, nobody wants to do a telemedicine. There was no concept of telemedicine. And as you know, the pediatrics, mainly you have to keep the mothers happy. So there was a lot of battle. People were adjusting to the setting of the telemedicine. As a physician, we were not very trained. So this was a survey of telemedicine by pediatric nephrologists, which got published in the KI. And it shows that most of the time people are using Zoom as the most important mechanism for the telemedicine. And it was inbuilt in the Epic, which is an EMR system, and 9%. Surprisingly, a lot of people were using DocsMe, and I have used it too, around 7%. It is like a website where you have an email, you send the patient an email, and then there's a webcam, you can record it, it's HIPAA protected. And some of the time the service not specified was 37%, and mix of local and small services were going on. Patients thought it was logistically more easier and equivalent quality compared to in-person visit. The doctors were concerned related to the technology issues, ability to procure the physical examination and result. But at least in North America, the concept of the COVID-19 came in. The CMS recognized the concept, and there was billing, and you can be billed on the basis of the COVID-19, and CMS was reimbursing the concept, which was not very much prevalent during that time. Now, method of telemedicine is very, very fascinating. People really like a video chat and telephone call. And it was mixed, 56%, and 23% patients just want the video chat. Only few people were doing the telephone calls, and text message, which is HIPAA protected via the chat message goes to the Epics, was not preferred by the patient, only less than like 8%. Training wise, we did not do very well because the epidemic was thrown on you. People were learning. There was a lot of challenges. Now we got some video tutorials, 42% of the time. Some of the institution gave you a PowerPoint presentation, which is 31% of the time. Email and written instruction, which our institution has done, was 17%. Only 6% of the physicians are trained one-to-one with the telemedicine. And this was what happened when epidemic comes and it throws you with the challenge. At least the paradigm was changed in North America. People were understanding the concept of the telemedicine, but everybody preferred to be a video form so they can see you, they can talk to you, and very few were using chat messages. Now, this is what the percentage of the experience of the telemedicine. You can see the blue is very satisfied and the orange is satisfied. So 57 overall experience with telemedicine, 57 to 58% was happy. And rate of the overall experience of using telemedicine was 56%, which is not bad. And we were very surprised and amazed to see the patients are liking it, the families are liking it as compared to adults. And I do both adult and pediatric nephrology. And the concept in peds was surprisingly to say that people are satisfied and they like, because there was no other option. This is a beautiful slide, and it just shows how the telemedicine span out to be. Telemedicine saved me time traveling to hospital, specialist clinic, 98%. And HCB is able to understand my healthcare condition. I was so surprised, 98% of the patients said yes. Do you receive adequate attention? They said 93%, because one-to-one, no distraction, you're talking to the patient. Think the healthcare provider provided via telemedicine is consistent. 90% of them, they thought it was consistent phenomena. And the best thing I like is whether your healthcare provider can understand you, hear you clearly, 90%. And the overall, the telemedicine provide my health care need, 88%. And overall, I'm satisfied with the quality of service being provided via Easy Talk to my HSP is around 80 to 85%. The fascinating point was people like, because travel time is decreased, they find a convenient time for visit. Amount of the time I wait for my clinician was very less, because telemedicine is one after another. When they come in hospital, you have a delay, you have to go to the hospital, you may be lagging. There is a lag between the nurses checking in, doing the vitals. Confidence, health concern can be taken care of. I was impressed. They liked it. They said, yes, it was interest. Cost of the visit was very less. Overall quality, they said it was around 50 to 52%. And connection was very, very spaced out. Some of the people who used DoxyMe or built-in Epic, they liked it. So this was positive or neutral, similar level of satisfaction, what you get in-house when they come and see you in person. So this was another paper that came out. It's the telemedicine of pediatric nephrology. How are you going to treat? Like suggested workflow, because you need to know the direction. And some of the workflows are very important, like acute nephrotic syndrome workflow. You need glomerular disease management, you know, COVID-19 and dialysis unit. What are you going to do? What's going to happen with the UTI and pediatric transplant telemedicine protocol? And this was all initiated to an extent that these are the common things that we are seeing in the setting, and we want to know the answer. How would we manage this? How are we going to do this? The biggest was, and transition, if they're transitioning during this time, how that can be done in home hemodialysis. We changed the paradigm. People are doing more home hemo. It's easy for us to remotely manage it. So hemodialysis was a big issue. If you have a COVID-19 positive patient, person who has tested positive for COVID-19 are clinically stable to treat in dialysis center, or clinically stable COVID-19 patient recently discharged from the hospital, they should have an isolation shift within the dialysis unit. And that was universal both in adult and peds. But person under the investigation with history and symptoms of COVID-19, this include persons who have been tested for COVID-19 and are waiting test results, and persons who have not yet tested for COVID-19. Treatment in a dialysis center must be cohorted into an isolation shift dedicated to the patients who are a person under the investigation. Asymptomatic persons reporting close contact, treatment in dialysis center must be cohorted into isolation shift dedicated to the person under investigation. There is a dialysis shift in the personnel. Avoid having healthcare staff change dialysis shift to avoid cross-contamination infection. Dialyze in a place with the rigorous use of personal protective equipment with isolation. Defer dialysis and refer a patient to hospital for testing and the treatment. So The big issue was, as all of you are the medical directors, we need to work on a CMS to make sure we are providing them an environment which is safe for them. And this is another one, is nephrotic syndrome. How are you going to deal with the nephrotic syndrome? If you have a patient who is kind of relapsing now, has a proteinuria and complication, you review the history, medication, urine diary, detail regarding the current illness, evaluate for complication. Then you have to look for any kind of systemic infection, NSRK, acute kidney injury, they need to come in. Relapse, what you do is you do prednisone daily, alternate days, reinforce ongoing therapy, review after 8 to 12 weeks. If they have a recent onset of proteinuria, screen for proteinuria at home, blood investigation, and counsel them regarding their relapse. So a lot of the nephrotic syndromes were managed as an outpatient, and that was a change in, at least in the pediatric world. Well, if you have chronic kidney disease, how are you going to do that? Establish a telemedicine platform for the video conference, and healthcare team has been trained. Patient's clinical status is deemed appropriate for intermedicine visits, scheduled for visit carried out by healthcare team members and patients and parents, have a combined family visit, go over with their staging, make sure all the 5 parameters of the CKDs are addressed: the blood pressure, acidosis, fluid electrolyte, CKD, MBD, and hypertension, and progression factors like proteinuria, diabetes, and other factors. And actually, anything that worked really well was the CKD care, because we were following these patients in a comprehensive family format, and that outcome was among the best if you look around in the setting of the pandemic. What are you going to do with the patients who has the problem with the transplant? What are you going to do? You have to be very careful if you have to discontinue any antimetabolites for the patient with confirmed or suspected infection. Consider discontinuation of the patient in sustained remission for 12 months. Be careful, not less than 12 months. Try to have a short-acting reversible agent over longer-acting infusions, so they don't have to be here in-house. Avoid therapy initiation for marginal criteria or non-standard indication for minimal symptoms. Convert IV to oral formulation when possible. Example, cyclophosphamide. Utilize home infusion services than rather the inpatient, and this has worked out very well. If the patient's in a clinical trial with potential patients benefit, continue drug study by sending medication to their home if an oral subcutaneous agent, or dosing in a COVID-19 compliant infusion center if it is an IV. So you cannot disrupt the clinic. Really limit blood draws to safety of laboratory performed at the other form. So the other thing is continue ACE inhibitors and ARB in the absence of clear indications, contraindications at this point. Continue prophylactic antibiotics. Encourage social distancing using masks outside the house. Office management was a challenge, and change all appointments to telemedicine if you can. Allow office staff to manage phone and patient message for home. Develop a standard script of recommendation for patient calling with questions. And that we did in our clinic. Develop, use telemedicine video visit rather than telephone call of the patient concerned about COVID-19 infection symptoms to best triage their respiratory status. This is UTI workflow. Suspect UTI. This was a very good algorithm given to the patients and to the staff. If they have fever for more than 3 days, with or without vomiting, low in pain, dysuria, urgency or frequency, ages less than 2, refuse to feed, lethargy, persistent vomiting or sick appearance, no televisit, refer them to the ER. If they do not have all these symptoms, urine routine microscopic culture sensitivity can be done as an outpatient. VUR or severe urinary tract symptoms, high fever with leukocytes and leukocyturia. Yes, you have to start empiric IV antibiotic. You can always bring them in or associate that with an infusion center. No symptoms, no growth, then you can stop. If you have a urine culture, significant growth, response at 48 hours, very good. If not, then you have to bring them into the hospital or you have to change an antibiotic. And this is another workflow that worked out to be very, very good with the patients with the UTI. Now, again, indications for a transplant recipient with COVID-19. There are a lot of guidelines. Now you have, I'm not going to go into detail with the transplant patient because this got very, very complicated with the patients. So indication to hospitalized transplant recipient with COVID-19, if they present with following symptoms, if they have shortness of breath, if they have severe respiratory symptoms, nausea, vomiting, confusion, progressive worsening fevers, if they have the tenderness, fevers, and sepsis, and those are the things you have to keep in mind. And these are like 1 year post-transplant, what are the calcineurin inhibitor dose, adjunctive agent, steroid labs, and clinical visit. We made it very clear to the team that this is what our algorithm would be. And if you define them on the basis of the time of the transplant, then these recommendations work very well with our staff. And a lot of the patients were managed on the telemedicine basis. The sickest part is 90 to 180 days when they're recently transplanted. That opened a little bit more concerning part than anything else. SARC virus, global online survey we did. There's a lot of children who are on immunosuppressions for kidney conditions. And what do? We did a global online survey, 113 children from 30 countries, 13 years mean age. Children on dialysis were 12, coexistent pulmonary disease was 6, cardiac 4, death was 4, and none was missed. And this is what the patients were. You have kidney transplantation 47, nephrotic 27, lupus 10. And we found out most of the time they're using tacrolimus, MMF, or cyclophosphamide. And the good thing was most of these patients were never admitted on immunosuppression 40% of the time. And they admitted with no respiratory support, 38%. Only 12% developed severe COVID-19 with a need of high floor oxygen need, and death was very less, 5%. So immunosuppression was continued and was considered safe because there was a lot of data on people who were coming around. Should we stop the immunosuppression so they don't get sick? That was not true. This is the survey that we did. It's very detrimental in this case. And only 5 patients was admitted to intensive care or death. And that was not related to the immunosuppression. It's just other comorbidity conditions admitted. They were admitted with. And only 4 needs high flow oxygen or BiPAP, and 3 were admitted to hospital, required supplementation of oxygen. And that's just show that immunosuppression was safe in COVID-19 era. And these are some of our data from European studies that came out. People who are on immunosuppressions or therapy for kidney disease admission cases with pediatric versus adult, there was not much difference. Now, this is SARC virus. We send a PEDSNF list with ESPN, ASPN, and ESPN to look the use of rituximab among the children with difficult nephrotic syndrome. And this was another issue that we deal with because these patients, they get very, there was a lot of concern because now rituximab is given more on a steroid resistant or steroid failure nephrotic syndrome. Should we give them a rituximab? They continued the use in 78%. And the median end children receiving rituximab per center pre-endemic was 1 per month. And during pandemic was 0.3. Only 33% have a hesitancy to use it, but most of them, they continued, which is 78%. Now, this is only 7% of these patients who are taking out of 436 rituximab has a SARS-CoV-19 median 4-month post-rituximab. So rituximab did not show that they have a higher incidence of getting COVID-19. And isolated cough was 1, isolated fever was 4, cough and fever was 8, cough, fever, and respiratory distress was 6. Required respiratory support, very few, only 3 of them. So this was also shown up, all survived, only 1 had an AKI, which does not need the RRT. Rituximab was good comparison to ESP and IPNA survey. Rate of hospitalization was less. There was a trend towards a higher need of respiratory support among hospitalized post-rituximab. And that's opened a whole can of worms about Why are we pushing and assuming and presuming these patients not to be treated for an immunosuppression? And kids are not an adult. They're not exposed outside. They're mainly in the home. They're well protected. And as compared to the adult, they have better immunology and immunoprotection, because as I shows, their IgG4 act very faster as compared to the children, to the kids. And you'll be surprised, we are seeing a lot of MIS and COVID infection in children. They get better more early than you and me, because they have, their immune system is very naive and they can combat with the chemokine response more than anybody else. At the end, I just want to end with our PCRRT Iconic Foundation paper saying what's going to happen when you are in a telemedicine talking to these patients. Always make sure if they are seriously ill and they have AKI, you assess their volume status daily on clinical examination, non-invasive hemodynamic assessment. Make sure these patients have an individualized fluid balance target in order to target children optimal volume status if they present with volume depletion, or avoid fluid overload in access, because fluid overload can lead to the worsening of the patient's respiratory status. Measure serum urea, create an electrolyte admission, and then 24 to 48 hours, because most of the time people, we don't go inside the room. If we have to protect our PPEs, we see them one every other day, monitor urine output, review medication daily, and withhold the one that may increase the risk of AKI. Protect yourself and team, limit exposure to healthcare staff, telemedicine, when to initiate, modality to use in resource-limited country. This is a beautiful article. Do what you have. What are you comfortable with? Start early. People do SLED and PD with hyperkalemia, profound acidosis, anticoagulation issue with CKRT. I will prefer CRRT if you have a cardiovascular instability, septic shock, metabolic acidosis, and cerebral edema. But this is just an algorithm for you. Act fast, because this is what is needed in the setting of CRRT in COVID-19. We came up with the concept. More data is coming about the high flow step down. We use for 12 hours a high flow and then step down to 25, 30, because this could help in the chemokine mitigation and removing all the excessive chemokines present. And that may be the new area that sepsis is moving into. Now, PCRRT recommendation, I'm not going to go and read it for you, but just there is a lot of extracorporeal support. We have used actually the Oxeris, but not the Cytosorb, although Oxeris is only approved in US above 18, not less than 18, but some of the Canadian groups were using Oxeris. So this is just your recommendation for the AKI. And again, this is a nationwide report from India. I just want to put it there, in a developing country, that the spread of the AKI or infections in these patients were pretty stable, nothing much changed. And even they are in a developing country, lot of social determinants, there was not much difference in the pediatric survival across the world. And this is a pediatric transplantation study, just shows the number of pediatric transplant by week. It's going up. It was put on halt, and still there's a lot of debate whether we should give them a kidney with COVID-19 or not. That struggle has been ongoing. To summarize, impact COVID-19 in pandemic and pediatric nephrology, not all children are spared, severe AKI, poor outcome, immunocompromised, affect dialysis and transplant care, community adapted telemedicine guides and recommendation. And that was a huge thing for the pediatric world, because we were not used, at least in US, we were not used to these kind of telemedicine. It worked out very well to an extent. Now with the pandemic is going to get over, and people really want that they should be seen by telemedicine, and that will make it very difficult, because the way the things are going on, maybe the CMS will come back and they will say that they will not do the reimbursement for the televisit. But definitely it has changed the paradigm for us. And that's what the study, and I highly recommend you to read the PCRRT Iconic Guidelines, our telemedicine paper. It has a very good algorithm for you in case if you want to. With that, I want to thank the organizers. Thank you for letting me speak early. And it was a nice conference, and I'm happy that I could be a part of it, although we are all flying to Canada tomorrow for the IPNA Congress, but luckily the date matched well with me. With that, I want to thank you all. And if there is any question, I'm happy to take.
Thank you very much, Dr. Rabish. Admin, please allow the video on my side, please. Dr. Haraga. Okay, I'll start with a question, Dr. Rabish. How frequent, from the start, we have been informed that the corticosteroids has some precautions during COVID-19. And you mentioned that your patients who are immune compromised because of the transplant status have been affected not much. So is this in general fact for all COVID-19 patients, or is it only for renal patients and pediatrics? Can you please explain a little bit what do you mean by that?
So I mainly deal with the transplant, both in adult and pediatrics. I deal with kidney and kidney pancreas. We have not adjusted the steroid. We left the way it is. We did not adjust the immunosuppression. The issue comes in when they come with COVID-19 with a I have a patient who has a kidney transplant, recent 6 month, came in with COVID-19. He did not take his vaccination, respiratory illness, and then he developed aspergillosis, which is also shown as a secondary infection, this immunocompromised. That gets very tricky because you have to stop the anti-proliferative medications like Celsat, because Celsat will decrease the immune. But steroid in general, when they are on maintain and they're more than 12 months after the transplant, they were pretty stable and I did not touch the immunosuppression medications, and they were not high risk to get infection. If they get it, they get it. For sure, if they get the transplant, patient got infection, they were more sick because they're immunocompromised. The patient who really did bad was actually the end-stage renal dialysis patients, because their immunity was low and they have a lot of comorbidity. They did worse when they got a COVID-19, but luckily they all got vaccinated. So I did not touch the steroids until they're in-house.
The second question, was there any, do you think that pediatric age group of transplant, they have the same features of adult transplant patients, or they, because of their pediatric, they have special precautions with telecommunication and telesurgery, provided the mother is happy, of course?
There is actually, if you look at the spectrum, kids are better, their immune profile is better. They respond to the chemokine better, and they tolerate the immunosuppression best. The fourth is they not have a lot of outside exposure. So as compared to adults, they definitely have a better profile and they got less COVID-19. And you can see, I showed you the data we did, patients on rituximab, which is getting infusion every 2 weeks. They did not have even a high incidence of the COVID-19. There were very few. So definitely they have a different profile.
I see. Thank you very much. Dr. Haraga, any question? He's our chairperson for today. Dr. Haraga, are you available? Well, thank you very much, Dr. Rabish. I think that's it. I hope that I'm with you, joining you to your trip to Canada tomorrow, but have a nice trip. Thank you very much for joining us. I'll be in touch with you again soon, hopefully.
Thank you. Thanks a lot.
Your presentation is impressive. We are so happy joining us for today. Thank you very much.
Thank you.
Have a nice day.
Yeah,
bye.
Bye.
So our next presenter is for today, Dr. Mohammed Al-Bura'i. Are you available?
Hello, good afternoon, everybody. Dr. Mohammed Harbi, I'm Dr. Mohammed Al-Bura'i with you.
Yes, please, admin, transfer the host to Dr. Bura'i so that he can share his screen. Welcome, Dr. Bura'i. Thank you very much for attending with us for today. Please allow me to introduce you. Dr. Bura'i is a well-known researcher and physician. And Dr. Bura'i, he's a Harvard Clinical Scholar Research Trainer, certificate in 2002. Dr. Bura'i is a well-known physician, and he has a specialty certificate in gastroenterology, Royal College of London, 2006. And Dr. Aburai has an extensive experience and positions that he worked on. Also, he get a lot of training and skills, which is really impressive. He's a member of scientific committees like member of the Asian Pacific Association of Study of the Liver. Currently, he's an associate editor in Hepatology International. He's a reviewer for very significant journals. He received a lot of awards and a significant number of publications. It's really a privilege, Dr. Burai, joining us today. Your CV is very impressive, and we are happy that somebody like you presented with us today. Thank you very much for your attendance, and please proceed your presentation. Thank you very much again.
Thank you, Dr. Harbi. I just try to share my slides. You see my slide now? Hello?
Yes, we see your slides.
Okay. First of all, this is my pleasure to join your interesting meeting. I will present telemedicine in Egypt, impressions from patients and healthcare workers.
But please make it bigger, Dr. Burai, because the slide is too small.
Okay. Is it okay now?
It is still small, but if you still have technical difficulties, we can overcome that. You can go ahead.
Okay. This is on my agenda today, an introduction, and I will talk about the pilot study and impression of patients, and impression of healthcare workers, and then a conclusion at the end. As all of us know, telemedicine and telehealth is a medical service provided from distance, consuming wired and unwired means of communication, and it's becoming popular thanks to the increasing demand of social distancing mandated by COVID-19. Both healthcare providers and patients started to implement methods of telemedicine to gradually replace some of the previously practiced face-to-face clinical service. Also, medical societies promoted the widespread use of telemedicine whenever possible to ensure safety of the community. Knowledge and skills of practicing telemedicine, availability of infrastructure technology, and logistic support are of paramount importance to achieve quality and integrity. Each country has to develop his own guidelines and legislations and policies to put telemedicine practice in the suitable legal framework before wide use in clinical practice. According to the WHO, telemedicine needs to have 4 elements. First is provide clinical support, overcome geographic barriers, involve various communication technologies, and improve health outcomes. There are many types of telemedicine. I think we have knew about that from the previous speakers, maybe like live video conferencing and store and forward or asynchronous videos, where the transmission of recorded health history to a healthcare provider who uses information to treat patients outside the real time. Another example is the remote patient monitoring, where the patients collect the data in an electronic form, and that data is transferred to the nurse or caregiver or a physician, And the last example is the mobile health technologies, which having a lot of applications that we are using nowadays. Briefly, I will mention few studies that I have done during the COVID-19 pandemic. In Egypt, this was the pilot study for treating hepatitis C patients in a remote area outside Cairo. It is very far from Cairo. It's called Baharia Oasis, and this place had around 200 patients diagnosed with hepatitis C, and they don't have the available consultant hepatologist to treat them. So we asked one of the general practitioners to come to Cairo to be trained on the management of protocol of hepatitis C. And then he was in contact with one of our consultants all the time during managing those patients. Briefly, we have treated 200 patients with a success rate of 100%, and very few reported adverse events were seen, like anemia in 7.5% of patients. This is the flow chart of the enrollment and the treatment of those patients. And this was a pilot study that was very successful and encouraged us to tackle the issue of telemedicine and how to apply and use it in Egypt. I did another study to check for the impression of patients about telemedicine in Egypt, and this was published in the International Journal of Telemedicine and Application, Knowledge and Applicability and Barriers of Telemedicine in Egypt. We have enrolled like 786 patients filling a questionnaire about telemedicine, and we found that half of the participants stated that they previously used telemedicine tool mainly to follow up laboratory results, and some of them used video or phone calls, and mobile applications were the most commonly recognized telemedicine tool. The participants exhibited a high level of knowledge and attitude towards telemedicine, and this was a little bit strange because we expected that nobody is using telemedicine till the COVID pandemic, but we found that they are using telemedicine, and only 20% of them thought that telemedicine could jeopardize their privacy, and a smaller number of those reported that telemedicine could lead to disclosing their medical information to people who are not authorized to do so. Also, there was a small amount, I mean, almost half of the participants agreed to strongly agree that the telemedicine service could increase the medical error, and 60% of the participants said that they are likely to prefer telemedicine than traditional ways, even if they thought that there may be some medical errors, and this was strange. However, 13% stated that telemedicine is more likely to be challenging to use. This result shows that the opinion of the patient on how difficult is it to use telemedicine service, most of the participants told that it is very unlikely to be difficult. And the blue bar shows the answer for the question, to what extent do you prefer to use telemedicine service than traditional way? And we found that 60% at least prefer to use traditional medicine over the regular way. So the vast majority of Egyptians perceive the benefit of telemedicine positively, and they were willing to use it. And there are some barriers that have been found, like people, old age people, and people who are have low level of education and living in some remote areas were not able to use telemedicine properly. So we recommended that further studies should address the utility of telemedicine in improving the quality of healthcare and patient health outcome and quality of life. Another study we did, we also tested the impressions of healthcare workers in different levels, technicians, physicians, and nurses, and so on, about telemedicine on a national level. We did also a questionnaire survey to ask them about their knowledge and experience and impression about telemedicine and the barriers for application of telemedicine, and if there is any additional service that can be utilized using telemedicine. Around 27% sorry, we enrolled 642 healthcare providers from all over Egypt, and 43.7% were females, and 55% were physicians, 27% were nurses, and 6.1% were technicians, and 7.6 were administrative clerks, and 3.6 were medical directors. Medical directors, by the way, in Egypt are usually physicians. So 64% of the participants reported that they have never used telemedicine. Smartphones were the most commonly used mean, and smartphone applications were the favorable service for about 50% of participants. Also, participants raised some concern regarding the privacy and security of patients' data. Regarding the additional services that can be utilized using telemedicine, the medical healthcare workers, I mean physician, so agreed that they can use telemedicine for psychological consultations, for interdisciplinary consults, for taking good medical history, for teaching students, but most of them disagree that we can use telemedicine in accurate clinical diagnosis or doing clinical examination. Regarding the additional service in nursing, the nurses thought that telemedicine can be easily utilized in all these categories of service. So we concluded that despite the fact that telemedicine appears to be appealing and widely accepted by healthcare providers, we still, its implementation is confronted by some obstacles, and precise organizational guidelines need to be developed to clearly figure out the exact role of each healthcare provider to minimize their doubtfulness about telemedicine and facilitate its adoption. In conclusion, pilot studies from Egypt showed promising results for the use of telemedicine in treating HCV. And despite the presence of some barriers, Egyptians perceive telemedicine and are willing to apply it. And telemedicine is widely accepted by healthcare providers in Egypt, and precise organizational guidelines need to be developed to clearly figure out the exact role of each healthcare provider to facilitate its adoption. And thank you very much.
Thank you very much, Dr. Muhammad. It's really a nice presentation. Dr. Haraga, any question, please?
Actually, no questions. I want to greet Dr. Al-Borai about this nice presentation and the very nice 3 studies. I think these studies, the first one about the satisfaction of the patients, which is
no, the first one was about treating hepatitis C remotely.
So the second one,
the second about one, yes, patient satisfaction, yes.
The one which is interesting for me that about 21% of the patients were unhappy or unsatisfactory with this telemedicine. It's almost the same percentage in the study which showed yesterday. That study was done in Saudi Arabia. So it's almost the same percentage.
Yeah.
The second thing I want to comment about about this the healthcare workers. I agree completely with you, and I think this topic was opened yesterday with other speakers about we need guidelines to establish guidelines and the legalization of all this telemedicine, because I agree with you and everybody that telemedicine can be very beneficial, especially in remote areas. It can provide some care for these patients who are living very away from the center or the big cities. Thank you very much, Dr. Borai, for this.
Thank you very much, and it was a pleasure and honor to be with you today. And thank you, Dr. Harbi, for inviting me to this important session.
Thank you very much, Dr. Borai. One small question, if you allow me.
Yes, please.
Did you across in your study anything about the cost benefit of telemedicine for the healthcare provider? Does it reduce the cost? Does it affect the healthcare system in general?
Yeah, we asked them about their opinion, but we did not do this systematically using figures or numbers. But we asked them if we use telemedicine, will this save cost? Most of them agreed, because this will decrease the cost of transportation, for example, and also the patient's time that is consumed outside their work. So if they can consult the physician after their work time, so they will not miss a working day. And if they consulted the physician from their home, they will not pay for the transportation, for example. In Egypt, we used to have patients moving from the south, from very far areas, to the capital, Cairo, to get examined, to be treated by physicians in Cairo. And this is very expensive, let me say. So I think, yes, it will decrease cost dramatically, and it will help patients save their time also in the work.
One more issue, is there, if we say that there is a benefit from telemedicine through, especially for the remote areas. The second question, was there any focus about how does the patient bill his doctor? I mean, who is going to pay and how he is going to pay?
Okay, this can be done electronically through a platform specialized for telemedicine consultation. I'll tell you one thing. I am a member of the medical council in Egypt, in Naqaba, the medical syndicate. I am the Secretary General of Cairo Medical Syndicate. So I know about the bylaws and the legislations. To do this telemedicine service, there should be an authorized and licensed platform to do the service. Not everybody can open his computer or a mobile phone and go to consult another physician through a web application. No, it should be a special service authorized and licensed by the medical council in each country, and should be supervised by the Ministry of Communication and supervised by the Ministry of Justice also, because telemedicine consultations can give wrong decisions. For example, if unauthorized physician did it. What I suggested here in Egypt is to do a list by all the providers, and then recommend doing 1 or 2 platforms, not more. And these platforms should be monitored, and all the consultations should be recorded, and there should be a consent form explaining the patient that this is an only online consultation, and it does not give you the full examination, and the decision may not be final, and you should ask your physician if you need to be examined or no. I imagine that psychiatric consultation can be done online, and some dermatology service can be done online, but not all the examinations. For example, the general medicine and the surgery, and for example, in our countries and our culture, we cannot do OB/GYN consultations online. So
Agree.
we have to put the roles
Agree,
together.
Dr. Borai, يعني up to your knowledge, يعني if there is any practical steps in Egypt to establish this the so-called official platform, or not yet?
Yes, yeah, we have already started this. The government already started doing a legislation, a law, تشريع يعني, law
أيوه.
for the use of telemedicine service. And this included not only physician, this also included the pharmacy and the other services that's provided electronically. And this law is discussed by the all the stakeholders, the Ministry of Health, the Ministry of Justice, the Ministry of Communication, and the medical syndicate. And now we are giving our input, all of us together. And we did a conference for telemedicine last February, discussing all those things together with the healthcare provider, the service providers themselves, the people who are having an online applications for telemedicine, to put all these together and to get a final law that is suitable and keeping the rights for everybody.
Excellent, excellent.
Thank you.
One last question, Dr. Burai. It's really interesting. I'm afraid that I'm asking too much, but I hope
No,
this
it's
is
okay. It's okay.
my last question.
Yeah.
Before you start your platform, was there a benchmark that you compare your services to? I'm sure
Yes,
that everybody is thinking to avoid starting from the scratch. So what was your benchmark that you compare yourself to?
we compare our service by some services provided in the Gulf areas and Saudi Arabia and the United Arab Emirates and USA. Also, they have a lot of guidance regarding this. But I was not involved in putting the law. I just give my input to the medical syndicate where I'm a member of. So we reviewed the law provided by the government, and we found that it's reasonable and preserves the rights. So we are currently reviewing the items of that law. But the benchmark that is present in Arabic countries is our reference in this.
I see. Thank you very much, Dr. Burai. I'm really happy joining us today with this extensive experience that you have.
Thank you very much.
I'm willing to contact you again after the symposium is over. Your experience is too much valid. Thank you very much.
Thank you very much for the invitation. Thank you.
Thank you much.
I think our next speaker is Dr. Tahir Jamil or Dr. Sanjeev Aram. Anybody from the speakers around? Dr. Tahir Jamil. Dr. Gulati. I hope I'm not missing anybody. Okay, I think I will resume my presentation, which I started earlier on. Till we have more speakers. So again, for oncology and telemedicine, OTN is simple and efficient for their members to connect to other providers, and the membership is expanding, accelerated between 2011 and 2012. OTN is primarily funded by Ontario province government. So OTN has a collaboration between Oklahoma Telemedicine that enables seamless provision of telemedicine services to many rural and remote First Nation reserves. In Canada, Health Infoway has also funded several significant development projects over the past 6 years. Both catalysts for telemedicine and service providers, OTN is leading a change to continue to simplify its use for institutions, providers, and patients. It has been indicated that the primary legal issue of telemedicine is the license and who is going to provide the license, who's going to provide the credential and privilege. 10 states medical boards issue special telemedicine license, including Texas and other states. And for credentialing and privilege, Joint Commission default rules is used. Overall concerns were raised that there is a little legal precedent to guide intra and contractual arrangement. most current regulation and statutory law regarding payment. So the first group, where the barriers and solutions for implementation has been discussed, that the goals of the technology and the institution which has been agreed for the pathway for establishing technology must be consistent with the institutional mission for medical practice. And the other essential covered that institution mission are education and caring for underserved patients. It was pointed that the regional care centers, RCC, and telepresence is currently used to interact with community healthcare providers for the cancer prevention program, such as tobacco use session. The panel cited a strategy that would achieve these goals, namely a phased process. And the group also emphasized the fact that central coordination was necessary to ensure compatibility of system technologies that connect RCC. Overall, the group agreed that the effective strategy of technology practice must be presumed the same outcome of the current institutional practice models regardless of the location. So in the clinical practice, which is a result about almost 20 separate tumor board meetings at the different times of a week, like a colorectal cancer within MD Anderson network, coordination would ensure that patients are triaged to the appropriate care centers that offers the best treatment for each patient, including clinical trials and other options. In addition, patients who could receive care closer to home would be identified and provided with appropriate options. It was noted that a multidisciplinary care of colorectal cancer was currently widely distributed and available on all sites, including the main campus and RCC and affiliates. The group noted that financial remuneration is currently distinctive for a peripheral site such as RCC. The consensus was that there needed to be agreement between RCC and the main campus regarding telemedicine services that would foster a relationship between providers and appropriately to build and facility respective expertise and capabilities. Such agreements would help clarify where patients would be initially seen and diagnosed and where they would receive a follow-up care. Each clinical service is unique and consequently has issues and constraints that need to be explored and solved with individualized technology program and interventions. Solutions that MD Anderson identifies in this context could become a valuable tool to provide clinical business models for other institutions struggling to make these same types of decisions. The group recommended that the best way to approach this problem would be a move forward to introducing a technology standard operating procedure within each separate clinical departments. And the tailored services are offered to be a complement with the current regulation and statutory provision. Many telesurgery systems are under development, but only 2 are currently available for clinical use. It consists of surgeon's workstation with a high-resolution color 3-dimensional image with adjustable magnification. The system included conventional surgical instruments, handles the surgeon to use, placed underneath the viewing screen. And the system was then developed commercially as Mona telesurgery system. As you can see here that this platform, which is almost like Da Vinci, consists of 3 table mount arms. You can see here that here is the patient, and this is the console where the surgeon, like in PlayStation, he's remotely doing his procedure. So this is a master-slave tele-manipulator where there were 3 modular robotic arms mounted in mobile trolleys that can be wheeled into operating theater. The first operation using the Mona system in humans was performed in Belgium. Larger operating reports are necessary to accommodate these complex articulated instruments. Until the recent inclusion of micro-RSTM technology, giving the instrument a wider range of motion inside the body, standard straight-adapted laparoscopic instruments were used. The system was first demonstrated in 1996 for remote suturing and performing anastomosis on cadaveric hearts, and then 1995 coronary artery bypass grafting operation in humans. So what are the benefits of telesurgery? The potential benefits relate to cost, convenience, and enhanced performance. And the telesurgery may also enhance the extent and the skill of the range of the surgery through its use of a robotic interface. Laparoscopic surgery has generally involved the surgeon viewing the surgical site on a small two-dimensional screen, often conventionally positioned across a table with a colleague controlling the camera. Additionally, many movements in the camera may lead to motion sickness in viewers. It is attached to the operating table and it's controlled by voice command with a foot switch. Magnified three-dimensional images allow precise positioning instruments. The thermal is eliminated and movements can be scaled. So that 1 centimeter movement of the surgeon finger might translate into actual movement of 1 millimeter at a remote site. And we discussed yesterday that tremor issue is quite significant part, but we have to understand that it is not that common to have such problem in surgery. So we have to put in consideration the cost justification about this part. The source of the technology allows surgeon to perform tasks that would otherwise be impossible, such as retinal vein cannulation. In cardiac surgery, control systems can produce a virtual heart arrest, allowing the surgeon to work on a motionless image of the heart while the movements of the surgery are automatically gated to the beating. Robotic devices can also be programmed to be interestingly safe, with movement restricted to an area where it can do no damage, and extremely large or small forces can safely be applied. The use of telesurgical counsel reduces the fatigue in the operating room surgery, and the surgeon performance should therefore remain optimal for longer. It has been estimated up to 54% of the surgical errors might be prevented, and direct interventions of an expert via telesurgery may improve the standard of surgical care throughout the world. While reduced costs for individual patients and surgeons may be benefit from telesurgery, to justify this expenditure, a significant clinical benefit to patients would have to be proven in terms of number of accuracy of procedures performed. Telesurgery may involve a number of specialist hospitals, states, or countries, and jurisdiction conflicts may occur. Conversely, it might be considered negligent to withhold access to telesurgery if it is available. Clearly, these medical legal issues must be addressed. Guidelines have been produced by the Society of American Gastrointestinal Endoscopic Surgeons, and there is still no consensus on how to determine the competence of telesurgery, nor in any way officially assessing skill acquisition. Licensing and regulations are another area in which there are few guidelines for the surgeon. One possibility is to develop a standardized set of procedures that must be performed with quantified measurements of skills. In addition to long-term evaluation of performance, the telesurgery systems themselves must be tested thoroughly. In Europe, this might be achieved by obtaining CE mark. Telesurgery might be potentially lead to negligence, detachment, and dehumanization. As the operative robots gain more autonomy, surgeons might become this skilled. The major concern about telesurgery related to its safety problems, such as loss of communication between the surgeon and the operating theater, telemanipulator system failure, or complications such as bleeding or direct cardiac arrest during operation require someone on site to take a charge of implement the correct procedure. A manual override option to any equipment must be made available. However, telesurgery system can be designed to be interestingly safe, with manipulators are restricted to designated safe area. Another safety feature and built into some systems is the safety freeze, whereby robotic arms will freeze if there is a power interruption, reducing the risk of damage to the patient from uncontrolled motion of the suddenly floppy arm. So what about teleconference? The teleconference and teleconsulting are slightly different from telemonitoring, in that they usually involve more demonstration, discussion than interaction and intervention. In 1997, Allen reported 1-hour broadcast of cholecystectomy over the internet undertaken as a feasibility study. While image quality was not perfect, it was good enough for viewing surgeons to identify pertinent anatomical structure. Another 3 broadcasts of live cholecystectomy on the internet were set up by GANSAS. Internet security was assured by emailing participants with the identification code of the broadcasting computer. The cost of transmission was equal to that of local telephone call, and the delay time of transmission was less than 1 second, with a data loss rate of 0.1%. A more private teleconference was performed between Netherlands and Hawaii, with a video from cholecystectomy transmitted via ISDN2 telephone lines. The image were blurred, and delay of 1,200 milliseconds was found in each direction. In 1997, new techniques for repair of heart valves was demonstrated live from London to surgeons in America using 3-meter screens to show close-up views of the surgery and the view from the head-mounted camera. Transmitting pictures at faster rate using ISDN6 lines remedied this problem. Live surgery demonstration can be transmitted to the teleconference and have been used in Japan to facilitate discussion and collaboration between neighboring hospitals. The session was interactive, enabling the question to be addressed to the operating surgeon. As you can see, this is almost what we do now in robotic surgery, the telepresence surgery, where the surgeon is operating the console and the operating console in one area and the robotic arms in a different area. Nowadays in Saudi Arabia, it is almost in the same operating room, but he's in the room beside. In 2001, the first international telesurgery was performed on a patient in France. A remote laparoscopic mastectomy was done. The delay was 155 milliseconds, safely below 300 milliseconds. The following surgical procedures have been performed using telesurgery techniques and systems available, with main aim of evaluating the equipment for clinical use and proving the concept. Therefore, the systems were tried short over distance without communications link over a wide area. To extend the procedure for surgery at a remote site would require one of the wide area communications. These procedures are laparoscopic in nature and follow the standard methods used for each procedure. The first operation performed using telesurgery system in humans was laparoscopic cholecystectomy. The 3-dimensional camera instruments for clip placement, lever retraction, grasping, and electrocution were controlled from the console 4.5 millimeter away from the patient. Downscaling of the surgeon motions by a factor of 4 was used. One case of preoperative bleeding was encountered, necessitating the blood transfusion of 1 unit. In 3 procedures, minor technical adjustments were made. the equipment and operation was converted to a conventional procedure in one patient on owning to unsatisfactory instruments. I think that was the last slide. Any question from the audience? أي سؤال يا أخوان؟ Any question, Mr. Chairman, Dr. Haraga?
لا تسلم يا دكتور حربي. It was a very nice review of telesurgery. Thank you much.
Okay, I think we are going to have a break for Asr time. So we will be back soon. We will be back after Asr prayer. So we'll have a coffee and Salah Asr pray time. We'll see you soon. Hello, everybody. We are back. We will sorry again, I think I missed the connection. We will start now about our next presentation. Anybody from the speakers available? Okay, we'll speak now about the telehealth in cancer care.
Hello, everyone, and welcome to the third session of the National Cancer Policy Forum's workshop on cancer care and cancer research in the context of the COVID-19 pandemic, lessons learned. This session is a roundtable discussion on telehealth and cancer care and cancer clinical research. I'm Dr. Karen Knudsen, CEO of the American Cancer Society and the American Cancer Society Cancer Action Network. I have the honor of co-moderating this session with Dr. Nekledov, professor of medicine at Harvard Medical School and the Brigham and Women's Hospital. We will begin with a keynote from Dr. Michael Kelly, professor of medicine at Duke University and chief of hematology oncology at Durham's VA Medical Center, as well as national program director for oncology at the Department of Veterans Affairs. We will then hear from 8 discussants. Dr. Robin Zahn, who is immediate past president of the Michiana Hematology Oncology and co-chair of the ASCO Telehealth Expert Panel. Dr. Inga Lennis, a senior vice president for practice improvement and patient experience at the Mass General Hospital Cancer Center and Mass General Physicians Organization. Dr. Paul Jacobson, an associate director of healthcare delivery research at the National Cancer Institute. Dr. William Dayhut, Scientific Director for Clinical Research, the Center for Cancer Research, and Clinical Director at the National Cancer Institute. We'll have a Food and Drug Administration perspective from Leonard Sachs, Associate Director for Clinical Methodology in the FDA Office of Medical Policy. We'll hear from Dr. Lee Flesher, Chief Medical Officer and Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. And finally, Dr. Michael McNeely, Director of the Office of Advancement of Telehealth at the Federal Office of Rural Health Policy at the Health Services and at the Health Resource and Services Administration. Please note that all bios are available in the briefing book and posted on the workshop website. And just a reminder before we get going, the presentations have been pre-recorded and will play consecutively. After the last presentation, we will begin the live panel discussion, but you don't have to wait for that moment to go ahead and upload your questions. We encourage your involvement in the workshop, so please use that chat box on our website to ask questions. We'll get to you. Thank you so much, and let's start the presentation.
Hello, my name is Michael Kelly, and I wanted to start by expressing my appreciation for the invitation to present at this workshop on behalf of many colleagues and partners who work on VA teleoncology and decentralized trials. VA is the largest rated healthcare system in the country with about 9 million enrolled veterans and about 6 million healthcare users. There are about 50,000 new cancer diagnoses each year with the demographics and cancer types as shown on the slide here. For today's talk, a third of enrolled veterans live in rural areas, which is about 2.5 times the national rate of rurality. VA is committed to implementing an oncology system of excellence. A component of that system is the National Teleoncology Service that was launched last year in 2020, and it evolved the Durham Teleoncology Service, which began in 2018. So VA National Teleoncology Service seeks to realign the supply and demand for oncologists with a primary goal to improve access to care for veterans with cancer, including improving timeliness of cancer care. So VA has very well developed telehealth resources, including national services for radiology, genetic counseling, and ICU services. The model is a virtual cancer center, which is analogous to an NCI designated cancer center, in which the providers have specialization in the patient's cancer type and are engaged in academic activities such as clinical research. We also want to improve the efficiency and precision of clinical practice. The initial focus is on medical oncology in the context of multidisciplinary care. And our target service areas are primarily smaller VA medical centers with some activity in other types of VA bricks and mortar facilities such as medical clinics and also outside of VA. So the model for the VA National Teleoncology Service is shown on the slide. In addition to the subspecialized oncologist, the virtual hub has a number of other clinical roles. Not shown are a palliative care provider, virtual tumor boards, and non-clinical support staff. The primary patient site is a clinic with an infusion on site where the patient is, mostly located at smaller VA medical centers. An on-site advanced practice provider is a requirement for comprehensive infusional services. We use non-VA care for services that are not available within the VA at the patient site, such as radiation oncology, surgical subspecialists, and some radiology services. So this map shows the location of the 9 activated patient care sites and 8 additional sites that are in the process of being activated. So I want to switch now to decentralized clinical trials. This slide shows a model that's described by Sean Kozin and Andy Karavos about where data is generated and where it's collected. And as we move more towards remote locations for the locality of where the data are captured, we move to this era of decentralized clinical trials. So compared to traditional site-based trials, decentralized trials are less costly. They have higher recruitment and retention rates. The participants can be more diverse, and therefore the results of the clinical trial can be more clinically applicable. And also, you can integrate digital tools more extensively in decentralized fashions. There are some limitations to decentralized clinical trials. In particular, if you're obtaining research biopsies or biosampling, such as pharmacokinetic studies, that usually is a significant challenge for a decentralized model, although you can obtain some samples. And then the other 2 limitations are registration studies, and those that do not qualify for FDA waivers are not appropriate for this. This is how we would modify the teleoncology service to account for virtual clinical trials. So the principal investigator and the clinical trial staff become a component of the teleoncology service. And then the patient sites are now more extensive than the list I showed you. It might include all of the sites within VA, which is about 130 practice sites for oncology, and maybe even out to the approximately 1,000 clinics that are present. So that when applied and is eligible or potentially eligible for a clinical study, they are referred to the trial in the context of teleoncology, where they're then connected with the clinical research staff. So we have 2 projects that are ongoing to sort of establish the feasibility of this. So one is a phase 4 study, which is looking at number of endpoints in patients who are being treated with an immune checkpoint inhibitor for cutaneous squamous cell carcinoma. The endpoints include efficacy endpoints, toxicity, and patient-reported outcomes. And all these patients are located across the country. The second study is designed for the intent of establishing proof of concept in relationship with a commercial partner. The patient population are metastatic prostate cancer and metastatic non-small cell lung carcinoma. The patients undergo identification through the medical record system, and then there's an attempt to recruit and enroll them in the study. The patients do an e-consent. They complete a questionnaire and are trained on the technology and wearable. And then they undergo follow-up over a period of 6 months to collect medical record and wearable data and patient-reported outcome at 4 visits. And then there's an exit questionnaire at the end for both the patient and the healthcare provider. So shifting to the last topic I'm going to talk about, which is the impact of COVID on cancer care in VA. So first, this slide just shows the overall impact of COVID on the use of telehealth in VA for any type of disease. This is all video telehealth, so it increased about 7-fold in terms of the number of visits. Has continued at that level since the pandemic. The number of visits per patient increased from about 1.5 to about 2.5. For oncology patients, the use of video telehealth increased about 5-fold in both the number of patients and the number of visits. That left the ratio of visits to patients stable at about 1.2. And again, you see stability at the tail end of the data. Cancer screening rates did decline in VA modestly, about 3 to 5% for cervical, breast, and colorectal cancer, shown on the slide. However, there is some additional complexity to the data. So for colorectal cancer, there was a sharp acute decline in colonoscopy in March of 2018. It has recovered to about 91% of pre-pandemic levels. While screening colonoscopy declined markedly, FIT testing was much more stable. The number of ordered FIT tests actually increased. The number of resulted FIT tests decreased. The follow-up from the pandemic era cohort is not yet mature, at least not as mature as the pre-cohort level. And finally, the treatment of active cancer appears to have continued mostly unabated during the pandemic. This slide shows stable use of 10 different anti-cancer medications. There's similar data for radiation and surgery. So thank you for allowing me to share the VA experience with you, and I look forward to the panel discussion.
Hello, and welcome to this roundtable discussion where I will be providing the oncology clinician perspective on telehealth and cancer care research. My name is Robin Zahn, and I'm a medical oncologist providing full-time patient care with Michiana Hematology Oncology, cancer specialists, a Midwest U.S. practice based in North Central and Northwest Indiana. My practice is an independent community oncology practice, and we provide outpatient care services in medical oncology, radiation oncology, radiology, IV infusion, and oral pharmacy. I have no relevant disclosures. Similar to most oncology practices in the United States, my practice utilized teletechnology less than 1% of the time pre-pandemic due to a number of factors, including but not limited to lack of technology access, lack of education for providers and patients on implementation of this technology, lack of public and private payer allowances to cover all oncology populations, and lack of consideration of telemedicine as an essential part of cancer care management services. The American Society of Clinical Oncology, the world's largest professional oncology society, otherwise known as ASCO, responded to the needs of its members as published in the following articles once the pandemic arrived. As a consequence of restrictions imposed, the utilization of telehealth oncology drastically increased variably, and for some clinicians, use was highly used for non-infusion visits. The report included a guide to cancer care delivery during the COVID-19 pandemic, published in the summer of 2020 and updated in December of 2020. The Road to Recovery report, learning from the COVID-19 experience to improve clinical research in cancer care, and 2 interim position statements, telemedicine and cancer care, and telemedicine cross-state licensure. Out of the interest of time, this slide highlights some of ASCO's recommendations regarding telehealth in response to member concerns. I would refer you to the prior slide for the references for a more detailed discussion in exact language. And these recommendations would include ASCO supports the flexibility CMS has implemented to ensure telemedicine is available to more practitioners and patients during the COVID-19 public health emergency, and urges CMS to maintain these expanded telemedicine policies beyond the pandemic. State and federal policymakers should make permanent and adequate reimbursement for all modes of telemedicine delivery by all plans and payers. Federal and state governments should promote universal access to high-speed broadband through expanding digital infrastructure. Federal and state governments should work to promote health equity through encouraging use of telemedicine in all care settings, including but not limited to rural and safety net providers. State and federal policies permitting telemedicine to cross state lines should include provision requiring doctor-patient relationships be established prior to provision of any telemedicine service. Medical liability providers should include telemedicine and data security related risks in their policies, and physicians should verify medical liability comprehensive coverage for telemedicine services, including across state lines in which they practice. And all states should participate in the Interstate Medical Licensure Compact, and lawmakers should enact legislation to join. In addition to the publications and recommendations discussed on the prior slides, the ASCO Quality Care Council established an expert panel, which was tasked with developing evidence-based standards to ensure appropriate methods of organizational care for oncology practices, healthcare practitioners, patients, and caregivers. On the left side of the slide, this is my co-chair, Dr. Ray Page, and the other members of the expert panel, which included a patient representative, physician assistant, and oncologists from both academia and community practices. The topics addressed by the expert panel included which patient should be seen via telehealth versus in person, important implementation considerations for oncology telehealth visits, establishment of the physician-patient relationship within the context of telehealth and oncology, the roles of advanced practice providers and allied health professionals in telehealth, virtual multidisciplinary cancer conferences, and the use of telehealth in cancer clinical trials. Of note, the expert panel's final recommendations are not meant to serve as a certification tool. Currently, this work has been submitted for publication, and we're hoping that it will be published before the end of this year. Thank you for your attention, and I look forward to our panel discussion.
Hello, I'm Dr. David Spiegel. I'm the Chief Scientific Officer at Sarah Cannon Research Institute and am a medical oncologist at Tennessee Oncology in Nashville, Tennessee. It's really a great honor to talk about telehealth, its impact in clinical research, kind of lessons from the pandemic. I only have 5 minutes, and I have 3 slides I want to walk you through. So we'll start with what I call the wins. I've been in a little bit of a baseball theme lately, so I actually theme this around run scored. That's how you win games. Here are the 4 kind of areas to think about in terms of real kind of wins for telehealth and clinical research. Our ability to avoid the delays of bringing people to town, whether it's a CRO or pharmaceutical partner, all the people that are involved in selecting a study, kind of approving a site, and then activating a trial. Those in-person meetings are certainly valuable, but the efficiencies gained by doing things remote allows you to open trials faster. And that's a huge win for patients and really for drug development. Also, our ability to screen patients. This is true, just in clinical care. A patient, before that patient decides to travel a great distance, even if it's from a rural setting to an urban setting, is a challenge. And so doing as much as you can remotely to educate, explain what research is, and even, decide if a patient looks to be eligible based on performance status and comorbidities, things you couldn't tell just by in paper, you only could tell in person. You could now achieve a lot of that by seeing a patient on a screen. Our ability to regulate and provide oversight for trials, we learned that this can all be done remotely for the most part. I hope that's a win that continues going forward. The expenses that are involved, the time that's involved in bringing people on the site, all that goes away when you can do things remotely. And also you've improved the access to data in terms of the amount of data you can see at one time and your ability to get to it over and over again. And then our engagement of colleagues, our doctors around the country who are involved in research, getting together on a platform that they're familiar with, understanding that you can do this at different times of the day, something we used to do, but was still clunky. A lot of efficiencies gained with the learnings of how to do a WebEx. I know that sounds silly, but it was a real win. In terms of kind of opportunities or strikes, I would say, the technology didn't always work. Even this could fail me right now for things sometimes you don't understand, whether it's lighting or bandwidth or something else unexpected. You still can have failures in technology. As well, a big surprise has been the fatigue involved. I think this applies to not just research, but everybody involved in research, involved in kind of a telehealth experience. There's some fatigue that gets generated by these meetings and conferences that used to be in person, but now are kind of remote in visual experience that can be draining sometimes if you're doing it time and time again every day. There's no shortage or shortcut, I should say, for the value gain for being in a room with a patient, for being in a room with a colleague involved in kind of developing a trial and developing, an understanding of the outcomes of that study. There's certainly no shortage for the opportunities of what you can learn when you're together in person. So those were, I guess I'd call those strikes or some of the downsides of only being kind of remote during the pandemic. And then looking ahead, if I put this all together, I think it's more efficient research and lower costs. And I hope that those things improve the patient experience. You're improving the ability for a patient to get access to a study. You're improving the chances that that patient can remain closer to home for everybody. And I think overall that would be a huge win going forward. I'm hoping we can embrace that and kind of build upon that. I know that was quick. Hope that gave you kind of some flavor of the experience of telehealth and clinical research, but I also looking forward to the opportunity for the kind of open discussion. Thanks for your time and attention.
Hi, my name is Inga Lennis, and I'm a medical oncologist and the Senior Vice President of Ambulatory Care and Patient Experience at MGH. And it's great to be with you today talking about scaling virtual care at an academic enterprise. At MGH, at its peak, we conducted almost 90,000 virtual visits a month at the peak of the pandemic, which is a 112-fold increase over our pre-pandemic levels. 6 weeks into the pandemic, virtual care accounted for 83% of the ambulatory volume, up from less than 1% prior to the pandemic. And in total, we've done 700,000 virtual care visits in 2020. So really, the focus of this talk is to talk about not only what we did, but also the tools in managing such a large enterprise. And I'm going to end with some of the ways that we're trying to reduce disparities and the ongoing work that we have within the MGH community. When we think about scaling virtual care across a large enterprise, which includes 269 practices in 55 different locations, that includes cancer care, we really thought about it in 3 different domains. One was practice operations, which is in the first part, the top stripe of this Gantt chart. And then secondly, we thought about platform and technology optimization. And thirdly, we think about policy and regulation, which are increasingly becoming very important. Under practice operations, we worked first on defining our virtual targets, creating standardized workflows, and adjusting our templates so that our schedulers could schedule appropriately in for virtual care. And then we've done a lot of local process improvement in support of our large amount of practices to make sure that virtual care is embedded for the future. We sustain a level of virtual care. About 30% of our ambulatory visits across the enterprise continue to be telehealth visits. And we're hoping that it will continue to be a major part of care at MGH. In our platform and technology optimization, we use the Zoom interface with our electronic health record. And that was something that was established early on, but we've had to innovate, especially as the public health emergency has come to an end in this area. MGH is in the Northeast with lots of small states. We see lots of patients across borders, state borders. And so we've had to integrate into our electronic health record decision trees that help schedulers to pair out-of-state patients with appropriately licensed clinicians. And that's been a large effort over the last month. And then lastly, we keep an eye on policy and regulation, which are so important and will have great effects on the amount of virtual care we do for the future, depending on what happens in the national level. This is one of the virtual care tools that we use to manage virtual care at scale. We monitor for operations, our virtual visits, and not only video visits, but telephone only visits. And you see that up in the upper left-hand corner. We look at trend over time, and also we can also drill down into each department to see the amount of virtual care that's happening. On the right-hand side of this tool, you also see health equity broken down by race, ethnicity, and the use of telephone and video virtual care. This is one of the newer advances in our large enterprise dashboard that we're really proud of and that we plan to take advantage of to learn more about the disparities in these areas and to then create targeted projects to remedy the disparities. We also monitor patient experience, and listed on the left-hand side are the questions that we ask patients after every single ambulatory visit, including virtual care visits, about the quality and the experience they had. It includes not only how the provider performed in terms of explaining things and listening carefully, et cetera, but also the connection quality, the technical support, and some of those things that are just only something that happens in telehealth. Our net promoter score, or our likelihood to recommend, is very high for telehealth. You see that it's 88.1, which is very, very high. 91% of patients recommend, highly recommends their telehealth experience. And this is actually higher than our in-person ratings. So lastly, we are united as a system to address disparities in access to virtual care. We've innovated with new things that we're working on across the system, including digital access coordinators, tools in multiple languages, loaner technologies, text-based video, and early integration of interpreters. We also are studying the optimal deployment of virtual healthcare, not only in cancer, but across many other disciplines, looking at barriers to acceptance, community determinants of virtual care efficacy, optimal health conditions for use, pairing wearable technologies and monitoring, and condition-specific research. And lastly, for the future, we have our eyes on our out-of-state virtual care compliance and regulatory considerations. And we're really trying to shift the conversation from reimbursement to value as we keep an eye on the possible changes to reimbursement of this valuable tool. Thank you to the people who contributed to this today, and thank you for participating.
My name is Paul Jacobson. I'll be describing several recent National Cancer Institute research initiatives designed to advance the use of telehealth in cancer care. I have no disclosures, but I do want to acknowledge the many colleagues at NCI whose activities are reflecting work I represent, including Drs. Roxanne Jensen and Robin Vander. Given the many steps in developing NCI research initiatives, our principal focus has been to try to anticipate what happens next. In light of the growth of interest in and use of telehealth we just witnessed, what should be a research agenda for telehealth and cancer care in a post-pandemic world? We believe the current situation provides an excellent opportunity to accelerate the pace of telehealth research and to expand its scope to include more of the cancer control continuum, as well as more points of the translational research continuum. It's also an opportune time to push ahead on research about how telehealth can be used to address longstanding issues in cancer care delivery, especially for underserved populations such as rural and low-income individuals. One of the first steps in our planning process was to obtain stakeholder input on scientific gaps and research needs in this area by issuing a formal request for information, or RFI. In the pie chart, you see a breakdown of the sources for the 46 responses we received. And in addition to reviewing the individual submissions, we performed a qualitative analysis that identified three major themes: the need to develop new approaches for integrating telehealth into delivery of cancer care, the importance of identifying and disseminating best practices for use of telehealth, and the need to focus on how telehealth intersects with issues of health equity and access to care. I'll add that the volume of responses suggested a strong interest in and capacity for conducting cancer-focused telehealth research. The responses to the RFI were summarized in the webinar we held in March that is archived in the web address shown on this slide. The other action we took early on was to analyze NCI's existing portfolio of grants in this area. We identified 21 grants, most of which are investigator-initiated R01s, that were studying some form of synchronous, that is real-time patient-clinician communication. The grants fell into one of three categories of care: supportive care, which is management, psychosocial care, and cancer prevention. And I've included some examples of each below. While these are all important topics, the list reflects a fairly specialized research focus. And what's notably missing is research of the forms of care that we saw rise dramatically during the pandemic. For example, the use of telehealth by the Department of Oncology team to deliver components of routine cancer care. So synthesizing this and other information we gathered, we concluded there's a need to encourage and support research that identifies those cancer care contexts optimally suited to the use of telehealth post-pandemic, that tests innovative approaches to combining synchronous communication with asynchronous forms of communication, such as electronic symptom monitoring, that demonstrates how telehealth might be used to reduce disparities and improve access to certain forms of care, And if we truly want to have a major impact, research that generates scalable, transferable, and sustainable models showing how telehealth can yield better quality of care, more efficient utilization of healthcare resources, and improved health outcomes. We developed two funding opportunity announcements to support and encourage work of the type I just described. First is a request for applications to fund centers on telehealth research and cancer-related care. NCI has set aside funds to establish up to 3 cancer-focused telehealth research centers in what we recognize as a changing healthcare policy environment. These funds will allow each center to establish a research infrastructure for testing telehealth-based models of care in real-world settings. And toward that end, each center is required to identify a clinical practice network that can serve as a laboratory for this work. Each center is expected to conduct a large pragmatic trial designed to generate findings with broad applicability and conduct several pilot projects that lay the groundwork for additional larger scale studies. We hope by funding these centers to accelerate the development, evaluation, and widespread dissemination of new evidence-based models of telehealth and cancer care. This RFA closed for receipt of applications on July 20th, and we expect to make awards early in 2022. At the same time, we also put out a broad program announcement in the form of a notice of special interest. This announcement encourages both R1 and R21 submissions on a wide range of telehealth research topics, and it includes within its scope research on both patient-provider and provider, as well as research using synchronous and asynchronous forms of communication. Full notice can be found at the web address listed on the slide, and a webinar recently conducted providing additional details is archived at the second web address listed below. As we track responses to funding announcements, we'll also be considering other ways to advance and support research on telehealth and cancer care. Thank you very much.
Good afternoon. Hi, my name is Bill Dayhut, and I'm the Scientific Director for Clinical Research, the Center for Cancer Research at the NCI. This is part of the NIH Clinical Center. And I want to talk today over the next 5 minutes about how we really changed the way we practice medicine at the NIH Clinical Center due to COVID-19. First, a little about who we are. So the NCI is really part of the NIH Intramural Research Program. And NCI, as you folks know, is one of the 27 institutes and centers. And the Center for Cancer Research is one of the intramural parts of the NCI. But it's important to realize that at the NIH Clinical Center, which is the world's largest research hospital, the NCI, although we're one of the 27 institutes, are about a third of both the adjusted patient days as well as the financial consumption by the NIH Clinical Center. Thus, in a lot of ways, we're similar to cancer hospitals as opposed to more traditional hospitals. Some unique aspects. Every patient at the NIH Clinical Center is on a research study. We do not have an ER. Patients don't walk in for care. Patients come from every state and international. Patients are not billed for any aspect of the medical care performed at the clinical center. Third-party payers, private or government, are neither notified nor invoiced for any care at the clinical center. We're a federal institution, so physicians can be licensed in any state, although the clinical center is in Bethesda, Maryland. And care is always provided in partnership with the local medical team. So wonderfully, the NIH Clinical Center really developed this telehealth concierge service. There's information in here more than you need to know, but essentially we would arrange a telehealth appointment, and then the NIH hospital would reach out to the patient, arrange the visit, and really arrange language interpreters and really help with communications for our visit. And here's some data. This is not just cancer, this is all of NIH. But you can see back in 2020, we essentially had no telehealth appointments. And as you can see, over time, this has increased significantly so. And interestingly enough, you can see the NCI cancer patients is a large part of that. Again, we had very few patients when we started, but over time, several hundred patients a day, all on research studies, remember, are now being seen by telehealth. So what do we learn? Well, we learned our research proposals need to be amended. We need to decrease the frequency of visits to Bethesda, which the protocols had said, and allow telehealth visits. Decrease requirements of physical examinations that we probably didn't need, and batch correlative blood work when scientifically feasible. We found that shipping of commercial agents was much easier than IND agents. And we need to facilitate the ability for patients to obtain clinical or research labs outside Bethesda. But obviously you need to work very closely with the sponsor, the IRB and the FDA. You can't simply just make it up as we go along. And we think this may actually improve diversity of our patients. Although we cover transportation, provide the stipend for housing, the economics of travel to Bethesda may impact certain groups disproportionately. Telehealth has the potential to lessen these burdens. It needs to be done, though, in collaboration with local institutions. And currently, we are looking critically at our protocol design, portative laboratory and biopsy schedule, as well as concierge services to ensure access to our clinical trials is enhanced. Further directions is really enhancing our telehealth service. And we really think by some of the things listed here on this page that will make this even easier for patients and really improve the ability for patients to be on our trials as well as increase our diversity. Thank you very much for your time.
My name is Leonard Sachs from the Office of Medical Policy, CEDAR at FDA. And I want to start with just a little bit of contextual background, reminding ourselves of the new urgencies that we saw in COVID-19, where ongoing trials were under threat. There were concerns about patient safety, who were unable to visit the sites. We were relying on technology that not everybody had. There were breakdowns in supply chains. There was inability to get lab tests. And in some of the trials for COVID-19, there were other challenges that required very urgent implementation. Data was needed for many treatment options. And a lot of these considerations apply to cancer trials as well. So clearly, one of the big solutions was going to be remote data acquisition, both in COVID and cancer. I think the convenience of these types of trials are self-evident for patients who have impaired mobility, cognitive problems, or they're missing work, have problems with childcare. For rare diseases, the advantage of going including patients in remote locations. We can sometimes get continuous or frequent data using technology such as sensors, smartwatches, and tablets, and we can get some evaluation of functionality in the real-world environment. So the overarching principle here is a decentralized clinical trial, which we regard as trials where some or all trial-related activities take place at locations that are separate from the investigator's location. And there's a list here of some of the tools that I'll go through: the use of video interactive tools, telemedicine, electronic informed consent, use of local imaging and labs, facilities, the direct distribution of patients of drugs to patients, real-world data from health care records, trials in the healthcare setting, which are known as pragmatic trials by some, the use of master protocols and remote data gathering using sensors and other technologies. As far as video interactive tools go, standard in telemedicine, and there's been some use in clinical trials. The concerns are obviously not being able to get data we need in person, for example, physical examinations, and they may present challenges for patient retention without individual patient contact. Electronic informed consent is already published in our guidances and is very much part of trials already. The use of local healthcare services, particularly of value in cancer trials, I would imagine. The use of local facilities for lab tests and imaging, which are major components of the research criteria. We also have local healthcare providers going to patients' homes. The risks are variability from unstandardized data from many different sources. And in this setting, superiority studies are probably more convincing than non-inferiority studies to show a drug effect. Direct distribution of drugs to patients is something that can be done. It was done during the COVID emergency, and many of the state and local regulations, which are complicated, were relaxed. But investigators have to track and control the release of these drugs. Shipping and packaging applies to drugs that are sensitive to temperature, and they have to be safely administered at home. I'm sure there's no need to emphasize that a lot of the data can be harvested from existing clinical data records, electronic health record systems, and so on. As far as trials in the healthcare setting go, these have the advantages of using existing infrastructure. They're convenient for patients, helpful for long-term follow-up in cancer patients. But we have to remember that diagnosis have to be simple enough to be made in a healthcare setting, that the outcomes have to be simple to determine and reliable to capture in the healthcare setting, and that trial procedures are generally part of care. A word about master protocols and trial networks, very helpful for introduction of rapid new investigational arms, using platform trials, and also for looking at different subgroups as part of basket trials, and they also take advantage of existing infrastructure. And remote data gathering using sensitive digital technologies, perhaps not that applicable to cancer trials, but biosensors can be used, such as ECGs, pulse oximetry, glucose monitors, and other sensors such as actigraphy, interactive apps, cell phone photography, etc. And they allow continuous monitoring and measurement of functionality, and they allow us to capture rare events like relation, for example, seizures, and they're used for patient selection, outcome assessment, and AE evaluation. And it's important to validate and verify these systems are relying on the data. Unintended consequences will obviously learn in due course which activities are allowed and which are not, which practices lead to variability or reduced quality of data. Outdated practices will disappear, and we're likely to rely much more on electronic systems. But I think it does present us with a new vision for clinical trials, both for investigators and for patients. I very much look forward to the questions that hopefully will follow. Thank you.
So I want to really thank the National Academy for this opportunity to present today. My name is Lee Fleischer. I'm the Chief Medical Officer of the Centers for Medicare and Medicaid Services, as well as the Director of the Center for Clinical Standards and Quality. And from telehealth, I'm also going to speak from my clinical perspective as an anesthesiologist who was practicing during the first 3 months of the pandemic. So practicing in that very remote setting, only actually performing cases that were absolutely necessary. And then coming into CMS a little over a year ago and really seeing how we should change our way of thinking about telehealth. So the week before the public health emergency, there were 14,000 visits. But during the mid-March through mid-September timeframe, there were 12.8 million visits, or 38% of all visits were telehealth. Clearly, those were E&M visits, they weren't surgery. But I think it's important to realize that it went to very high levels and now really has returned back in most places to normal. But what's the right cadence for our patients and to achieve the best outcomes? And these are some of the key questions we're starting to ask with the data we have. We paid the same during the public health emergency for remote visits, for telehealth, and we paid at the same rate. And we know that post the public health emergency, at least in the fee-for-service program, we're going to be addressing the question of what do we, from a statute standpoint, are we able to continue? We know that mental health, we are continuing, even audio only. What can we do for E&M? What can we do for cancer care? What, as opposed to what the Medicare Advantage plans can do, which they have much more flexibility, as what is the flexibility in our models? And I know that there will be another talk about that, but I'll talk about it also here. And as I think about this, it's if we were in a model, if we had the total cost of care, as I, as a health services researcher and clinician, think about it, what would we do for our patients to achieve the quality of care, the same outcomes, if we were able to match it? And certainly with this particular administration's focus on equity, and in fact this time with our important focus on what we saw the inequities in care and where we want to, what we want to achieve, does it matter the type of telehealth? Do we need it over Zoom or some other where we can actually see a visual picture? Can it be done by audio only? And does it increase or decrease disparities depending on the population? So I think that the key questions that we have to answer before we really know what are the minimum standards, what should we get to, really is we have to do some more research. Some we need to lean in and do the research literally while flying the plane, from my perspective, as we sort of allow certain visits, because we do that already in bundled care, and allow the clinician the opportunity. Post-op visits can be done certainly in bundles with having cancer surgery. The other question is, from my mind, how do we look at the initial visit that somebody may need, where they say, I'm worried about something. You may or may not need the physical exam. How do we pivot into the issue of the history, then the physical, depending again on whether or not it can be done just visually, or you really need to have palpation, that you need to be the served person, or it can just go straight to some radiographic or some way of imaging for the techniques. Then how can we think about, and this is even a colleague used this, using telemedicine to get second opinions or to coordinate with greater subspecialists so that the team can work with you, and sometimes even maybe having two members of the team who may not be in the same institution coordinate with the patient to get them the best care for specific cancers that require that greater subspecialization. And finally, it's going to be important to think about that cadence of surveillance. And again, if it's imaging, that's most important. Should we think about, can we do this all through telehealth, through telemonitoring after the case? So in brief, I think CMS did see a positive uptake during the PHE. We're looking at what we can, from a regulation standpoint, based upon statute, sort of look at afterwards. And as a member of the NAM and a health services researcher, I think it's going to be really important that we provide the community as well as the policymakers what is the best way to achieve excellent outcomes or similar outcomes that is equal for all populations using these new modalities combined with in-person visits. Thank you.
Good day. My name is Michael McNeely. I'm the director of the Office for the Advancement of Telehealth within the Federal Resources and Services. Telehealth has been cutting-edge delivery methods for healthcare that has provided much-needed access to evaluation and treatment of rural and underserved populations. Telehealth provides the opportunity to be a cost-effective alternative to the traditional face-to-face care delivery models. It's important that we have a full understanding of how we define telehealth. First, it defines telehealth as the use of electronic information and telecommunication technologies to support and promote long-distance healthcare, patient and professional health-related education, public health, and health administration. The technologies involved in telehealth include video conferencing, the internet, store-and-forward imaging, streaming media, terrestrial and wireless communications, and mobile phones. Telehealth has an enormous benefit and is particularly relevant in rural and underserved communities. Increase in access to services, development, and care. The benefits of telehealth can be subdivided into benefits to providers, patients, and payers. The telehealth benefits for providers include improving workforce development, improving care delivery, serving more patients, and it lowers the notion of patients. The telehealth benefits for patients include increasing access to care, reducing travel, and lets the patient stay in the home. As it relates to payers, it reduces the cost of transportation to allow for more timely care to produce better outcomes that save costs. With the onset of the COVID-19 pandemic, additional benefits of telehealth were demonstrated. These include limited potential for exposure to the virus for healthcare workers, reduction of risk of exposure to the virus by persons outside the patient's home, and increases in allowable telehealth services. Although there are numerous benefits to telehealth, barriers to advancing telehealth remain. The 5 areas with the biggest issues are reimbursement, licensure, prescribing, credentialing, and broadband. During the pandemic, some of the barriers to advancing telehealth have been addressed through flexibilities. These changes are temporary. Most of these measures will sunset in public health emergency. Some of these changes include, for Medicare, geographic restrictions for patients or providers were lifted. Eligible services were expanded. All healthcare providers eligible for Medicare can bill for telehealth services. Providers can reduce or waive the cost sharing visits. Providers can furnish services outside of the state enrollment, and audio only became allowable. For Medicaid, the coverage differs from state to state. Most states have expanded Medicaid coverage for telehealth, and many states now allow audio only. Home is the originating site, and coverage being telehealth services. Almost every state has modified licensure requirements and renewal policies for providers, including out-of-state requirements for telehealth. Within OAT, we fund a number of programs that support the advancement of telehealth. These programs provide opportunities to build the evidence base, identifying solutions, and providing resources and technical assistance to providers. 4 programs of note that intersect with delivery of care and respecting cancer diagnosis and treatment for telehealth include our telehealth technology and learning program, whose purpose is to connect specialists and academic medical centers with primary care providers to provide evidence-based training and support to help the treatment of patients with complex conditions. Telehealth centers of excellence use their expertise and service incubators to pilot, track, and define telehealth research and practice. And our telehealth resource centers will provide technical assistance, education, and resources on various topics. We have 14 of these, and 12 of them are regional, with 2 serving as a policy and technology specialists. The TRCs have specializations in a number of topics, including telegenetics, teleoncology. Finally, the licensure and portability program provides support for safe professional license boards and carry out programs under which license boards of various states cooperate to develop state policies that will reduce statutory and regulatory barriers to the provision of healthcare services, telemedicine technology. Additionally, HHS and HRSA launched telehealth.hhs.gov in April 2020 in response to the pandemic. This website is a one-stop resource for patients and providers for everything they need to know about telehealth, best practices, how-to information, policy, and reimbursement updates, and implementation resources. 2020 has shown us that telehealth provides significant benefits and has played a key role in reducing the disruption to healthcare services. Telehealth patient populations have expanded beyond rural and underserved areas of this adoption across a range of specialties. HRSA believes telehealth will continue to grow, and our goal is to continue to be a leader in the field. We continue to monitor changes to telehealth regulations and work with federal partners to build strong telehealth partnerships. Finally, know that HRSA's vision is to continue to work across HHS, leverage telehealth activities in order to advance the field of telehealth. We will continue to work with across HHS with CMS, NIH, ARC, CDC, and ASPR, and other departments, including FCC, NTIA, and USDA, to link across programs and leverage activities. Thank you for having me today.
Well, thank you for those incredible presentations. So now we will have some time for panel discussion. So I invite everyone to join us, Zach. So just a reminder for the audience, please enter your questions into the box that appears as you watch the webinar. And I will ask the first question. There's so many questions to ask. I don't know where to begin, but I'll start with this one. So telemedicine has the potential to improve. It also has the potential to exacerbate disparities in cancer care and in cancer clinical trials. Going forward, how do we improve and not exacerbate potential disparities? And I think I'm going to put most of the speakers on the hot seat, but the one that I'm seeing now is Dr. Zahn, so maybe you can start.
Great. So the disparities that as those noted, and we have just personally in our practice, is access to broadband and technology and familiarity with technology. So the value of the telehealth in the pandemic standpoint is that audio was allowed. So very often we were able to use audio without an audio-visual component for patients who are either inner city, in other words, they couldn't come to us because they have transportation issues, or rural. Most people we found did have access to audio, had neighbors who could come over and give them their phone.
Audiovisual, however, was much more difficult. Either they didn't have the broadband and the internet access, or they didn't have the technology to be able to do a video conferencing. So as ASCO has advocated, and as we clinicians would like, of course, is increase in broadband and digital health infrastructure, which actually was led by the educators. They really started that, you know, when all of a sudden our school children had to be educated at home. So they really were the leaders, you know. At the same time, we started using telemedicine. You know, so certainly, you know, there are some barriers, and how we overcame it is by using the audio technologies. So we would advocate, just from our day-to-day practice, that we continue to have accessibility to the audio aspect, being able to deliver telehealth for those individuals that don't have access otherwise. Certainly there's some creative things that are being done, you know, across the world, as well as potentially locally, and that's developing hotspots. The educators, again, taught us about that, at least here in our community. For the areas in town that didn't have infrastructure and broadband, they would take buses, school buses, and had a hotspot in the school bus so that people could go to that hotspot and be able to do their education. But that same concept could be applied as well to neighborhoods in terms of where you're trying to deliver healthcare, you know, in the face of not having access to broadband otherwise.
Thank you. So, Dr. Lenis, can you comment on that as well? What has MGB, a large organization, done during the pandemic, and what do you plan to do going forward?
Sure. Thank you. So I agree with Dr. Zahn that pay parity for audio visits is incredibly important. We also found some success with loaner technology, so access to actual devices that could help during this time. We also needed new infrastructure and many more resources for our interpreter services. So when we bring telehealth along for our actual providers, we also needed to consider all of the faculty, all of the staff that are interacting with our patients in person. So that's not just our healthcare providers, but they are our schedulers, our interpreters, and all of those people that are interacting with patients one-on-one. I'd also say that the other really interesting thing that we're watching is the use of hubs and kiosks. So partnering with some industry partners, like I am aware of programs that have partnered with our pharmacy colleagues to put access to telehealth right in our local pharmacies in the communities where patients are, so that they can travel to those places and be able to access virtual care. So those are some of the things that we're watching for the future to help to reduce disparities.
Thank you. And then Dr. Kelly, so the VA has been doing this for a while. So I'm wondering what mechanisms you have in place and what you're planning to put into place to reduce disparities going forward.
Yeah, so we have some of the same disparities in terms of sophistication in dealing with the technology, or even access to technology. And some parts of the country don't even have Wi-Fi access or data access, even to a cell network. So there's some of the strategies that we've done, or you mentioned. So obviously educating the patient and their family. We've also been doing some partnerships to establish what we call pods, in association with veteran service organizations and some commercial entities such as big box stores. So you can go shopping and get your telehealth visit at the same time. And then loaner devices, we will send the patient a hotspot and a iPad so that they can talk to us. And then there'll be some follow-up communications on how to use them. So pretty much parallel a lot of those. And I think it sort of emphasizes the disparity that is underlying our societies, is that there isn't access to broadband internet, or even any internet in some parts of the country, and that is a disparity that impacts not only healthcare but every other aspect of our life.
Great.
Maybe I can. Oh, sorry.
Yeah, go ahead.
I was just going to say, maybe I can follow up a little bit on this one. So we've heard a lot about the disparities created by lack of Wi-Fi. But then if you take that on a little bit further and you're in an urban setting, like here in Philadelphia, where there's ample Wi-Fi, it's the case that as we at Jefferson Health escalated our telehealth usage, understanding we were already licensed to do it and already doing it, our big challenge was actually in digital literacy, of everyone having a smartphone, but not using it like a smartphone, not knowing how to download apps, and frequently not having
email address. So we had to deploy our social workers to use FaceTime to actually get people to learn how to set up a Gmail account so we could actually do a telehealth visit. So there was a significant amount of time, effort, and resource that had to be devoted to that. So I'm wondering if there was, from our panelists who escalated to telehealth, anyone, did you have a similar experience? Did you have an alternative solution outside what we did, which was really a quick Band-Aid?
So we actually did in the VA. We have that same experience. So sophistication of the patient is really a big challenge. So we did overcome the email issue. So some patients didn't have email addresses, and our technology originally required an email address, but they made a modification to the technology. So now you just need a cell phone number, and you can basically do FaceTime through our platform with just knowing the email, the cell phone number. So that's one approach that I think could be available.
Dr. Lennis, did your system, since you escalated so much, or Dr. Dehat, what did you use to get over the digital literacy divide?
We found that texting, just as Dr. Kelly mentioned, was a huge key. Lots of people use texting. So having a text into the portal, our virtual care system relies on our patient portal, which can be tough. So creating a workaround for that can work from a text message directly into the system, and then also having a second system. So we use a primary embedded system within our EHR, but then we also have trained our providers on a secondary system that doesn't rely on that. So we actually have a backup system that we use that is approved and also compliant in terms of safety for medical information. And that was really important because that gave us some alternatives to use for patients who couldn't navigate the initial system.
So Karen, obviously our numbers are smaller, but obviously they're all clinical research patients. So we actually had what they call a concierge service, would actually call the patient the day before and sort of walk through the technology with them, make sure they could connect and sort of do it step by step. So by the time of the patient visit, by and large, the patients were up to speed to what can be done. And so, again, that wouldn't work everywhere, but that is something for clinical trials potentially that folks may want to sort of integrate, as you're working with your sponsors. The other thing that I liked about telehealth is that allowed us to bring in family members from different geographic locations much easier. So again, with people that were flying to Bethesda normally, now I could see the patient virtually in Arkansas, but their daughter or son in California could be on the call too. So that particularly patients whose literacy about complex clinical trials was not ideal, having a family member who may be more in tune with what's going on, I think is particularly helpful. So,
and let's just say from the federal perspective, it's complicated. And Karen, I live in Philadelphia too. Just go midweek, but what we've got right now is the fact that the PHE is still a federal PHE. So therefore, we have our allowances under the federal PHE, but the states are actually terminating their federal PHE. So I get calls from family friends all the time saying, you're stopping telehealth across state lines. And it's like, I can't do anything from a federal perspective. So I think there's a lot of discussions federally about these sort of issues and what will happen when we terminate the PHE, and therefore the flexibilities go away.
Yeah, that's my new role. So, speaking now as the CEO of American Cancer Society and ACS CAN, our advocacy group is attuned to this and really hoping to help at the local and state level. But, from the disparities perspective, I think it's important for us to think just beyond Wi-Fi. If Wi-Fi were plentiful, what you're hearing from this group is there are a significant number of additional barriers that will have to be addressed in order to truly enhance access to telehealth, across all areas and demographics.
And it's also the affordability of Wi-Fi for many people, including people in urban settings where Wi-Fi might be plentiful, but they can't afford a plan.
And the value of asynchrony.
Yeah, so these are all really important points, and I think since we already touched on some of the additional barriers, I'm wondering if the group can expand upon the other barriers, which specifically licensure and insurance coverage. So who would like to take this one on first? If not, I will call on someone. Well, so Dr. Kelly, again, as the VA, right, you probably have the most flexibility on both accounts. So is there anything that you can tell us that can help us that are not working in the VA type setting?
You can all work in the VA. That would solve the problem. And that would be a great solution. We could actually have the NCI VA DoD consortium. You can all join us. But I think if you look at the quality of medical care that's delivered at the Cancer Center, at the NCI Clinical Center, at the VA, the DoD, there's really not an issue of I'm licensed in Michigan and not in Ohio, and therefore my quality of care is better. So it's not really clear to me why there can't be cross-state licensure other than the I guess maybe the Constitution or the way the country came about, but practically quality of care should be exactly the same. So that's the model that we use, just like Bill mentioned for the NIH, is that you need one license in some state, that's enough. And then in terms of the billing, as you know, VA provides its own coverage. We do bill second party insurers. If the patient has a non-federal government insurance, we will bill them. But we don't really make decisions based on whether the patient has that coverage or not, since it's a small minority of patients that actually do. So we don't really have that issue. So I guess the other solution would be single party payer, Medicare for all.
Now you're getting into deep territory, Dr.
Yeah, I know
run centers that have the border states have run into the technical hurdle, the time constraint, the cost of getting licensed in multiple states. So I think that's something that we're all hearing is a consensus here is let's see what we can do to eliminate that barrier. What would have to be done in order to achieve that?
And I think that was a question that was posed earlier. Is okay, great, it's a great idea. What are the downsides, and how would you make that happen? Is it a federal? Would you have to have the states agree with each other? So can New Jersey and Pennsylvania, maybe Delaware, agree to have cross-state licensure? Are there other professional licensure situations where that is going to be happening? I don't know. This might be something for our state medical societies to get into, or our professional societies in oncology.
So I know that Dr. So Dr. Zahn wanted to respond to that. I just saw.
Sure. There's a couple comments they'd make. So prior to the pandemic, of course, we, like for our locations, for example, we take care of patients in Indiana, but also Michigan and Illinois, because our practices are right across the state border. We only had to be licensed in the state of Indiana if the patient came to us. However, many of us had licensures in other states, so we could do simple things like prescribe controlled substances for our patients in the state of Michigan. But when the pandemic hit, you had to have the ability to be licensed to be able to counsel that patient where they lived. So for my colleagues who were licensed in the state of Michigan, they could counsel our patients who were in Michigan by telemedicine. But I was only licensed in Indiana. So I could not counsel my patients who were in the state of Michigan unless we went across McDonald's across the state line and they were sitting in Indiana at the time that I counseled them. So that being said, as somebody had mentioned, each state has their own particular specifics when it comes to physician licensure. And it impacts a lot of things. It impacts your DEA and how you get your DEA number, your pain medicine requirements. It impacts your medical malpractice insurance as well as the medical practice process. So that's very state specific. So when it comes to the licensure issue, as you know, there's the Interstate Medical Licensure Compact, which was launched in 2017. And in fact, it's a voluntary pathway for licensure physicians wanting to practice in medical states. It's voluntary. It's not a federal mandate. So there's only so many states that are participating in it, and it does not include Indiana. So for our particular practice, my colleagues were able to take advantage of counseling patients in Michigan or Illinois if they had a state license, or I had to go ahead and get a license for Michigan, for example. So right now, we do in fact have this contact available, and ASCO Advocacy has been encouraging state legislators to go to the state to allow for that IMLC, which is the short version of Interstate Medical Licensure Compact, to be available for their physicians. Now, there's some pushback from that. Not all physicians are in agreement with that. They're concerned about unfair competition, or they're concerned about other issues. For example, if you have a patient that's your patient and somebody comes in from Oregon, I'm just going to pick on Oregon, and they start taking care of my patient, and then somehow they make some decision, that patient comes to me and there's some fault, there's some issues with that, what position does that put me in? I'm saying this is what I've been told by my colleagues. And so there are some concerns, about competition when you follow that Interstate Medical Licensure Compact, but it has been in place even before the pandemic.
Great.
Thank you. And Dr. McNeely, can you comment on this as well?
Yeah, no, I was going to comment on that. States, two territories, DC, also a big part of that, though, is that it is voluntary. These are states that happens at the state legislatures, and that's why it won't be a federal interaction, to be honest, because this goes into the state's rights issues, and how they determine how Medicare is to be distributed in their states. The other part of that is that telehealth in itself is geographically restricted by law. It can only be done in rural areas at the moment. Until that changes and that legislation changes outside of PHE, it won't expand as fast as we want it to. And that's a big issue. That's one of the things we've battled in program side of things, because we are limited to where our services are provided. They can, an urban area can provide the services, but it has to be delivered in the service area that's outside. Indiana is a good example of being a state in the compact, or not in the compact, but is surrounded by states that are in the compact. And so if service was to be done in Illinois, they could serve Michigan pretty easily because of the compact situation. And there are probably, I've lost track of how many other compacts there are currently. There's 7 to 8 more that are between the nursing compact, side back, and the physical therapist compact. There's a number of things that are in play now to try to advance that licensure issue. I don't know that the federal government or Congress wants to take on a national licensure initiative. I don't know that that they have the fight in right now with everything else that's going on when it comes to it. So they will probably push the compact route because it has been expanding. I mentioned that there's 33 states that are involved. Most recently, we started this month, and that was Ohio. And so it's just the fact that we have the opportunity to, educate the state legislature, get them to understand why it's important to be part of the compact. We have an opportunity there. Our programs actually fund the Federation of State Medical Boards for the compact for ILMC, but we also work in other affordability issues.
That's really helpful. So maybe we can shift gears a little bit. So, we talked about the positives of telehealth. It's here to stay. There are a number of benefits we already outlined. We outlined barriers at the level of the financial model that surrounds oncology and complexity of logistics of pulling off telehealth. We identified barriers for the component of patient and digital literacy, access to Wi-Fi, et cetera. Let's talk about some other ways to push on how we might improve. So there's a question actually from the public chat from Jamie Weiner from the Oncology Nursing Society asking, is there a future consideration for including nurse-led RN interventions for coordination of care, symptom management via telehealth and value-based care payments? So let's go there.
But in value-based care payment, depending on the model, it doesn't have to follow our fee-for-service rules. So there, it's going to be a lot about the states and what you're actually practicing, as opposed to, you know, the approach that we would take in the traditional Part A's and Part B fee-for-service model.
Okay, so that's really helpful. What's been done from the groups that are here on the panel already? How are you employing nurse-led components of telehealth, or are you?
I'll just, Karen, I'll take a stab at that. David Spiegel. So we, we're in a large community-based practice in Middle Tennessee. So we have a whole palliative care team that connects with our patients through telehealth. And so I can have a visit in person or via telehealth, and then set up a palliative care visit that can happen remotely. In fact, much more easily than if it was in person. So we use them pretty frequently.
So can I follow up on that? How was that received by the patient to have a palliative care visit by telehealth?
I think it's, my experience has been they never really always understood why they would see another person at the appointment with me, and they didn't quite understand that flow. And so this becomes a distinct appointment that I think they can focus on, know that's coming up, and separate from the visit with me around chemotherapy, et cetera. I don't know, I can't speak for all patients, but I think it's been well received.
Any others like to comment on the role of APPs or RNs in the process?
So I'd like to make one comment. So there's something called triage pathways that many community sites have adopted, across the country. We have not specifically used our RNs in a telehealth capacity, but we do have local triage pathways. But there are other triage pathway groups that are actually using it for telemedicine in larger groups, where in fact they have the nurse, and oftentimes it may be a PA or an NP that's directing and driving that triage pathway. And they've been very happy with that. They've been able to show already reduction, even pre-pandemic, reduction in ER visits and hospital stays.
Okay. Dr. Lennis, what about you?
Yes, we're incorporating many different nurse-led initiatives in telehealth, including post-discharge visits with our RN and APPs. Like Dr. Spiegel, palliative care is using this, and then our pharmacy colleagues who join us for certain reconciliation efforts, med reconciliation, chemotherapy, teaching visits. We've been using some telehealth features for those since the pandemic started to really good effect. Great patient experience numbers. When we look at the satisfaction with these types of visits, it's convenient for patients. They save on parking. They're able to pull their family in to be able to hear the chemo teach at the same time. We find them very effective, and our researchers that are doing health services research are also finding that these are great opportunities, especially when you pair them with wearables. So there's some studies that we have going on where we're not only using telehealth visits with these expanded role groups, but also using some wearables to collect some actual objective data during this time as well. So a lot of great things for the future, I think.
Okay, so we're hearing about the incorporation of other practitioners, incorporation of wearables. What else are we missing that can improve the quality of telehealth?
The interesting question, if you listen to Liz Fowler, my colleague who oversees the Innovation Center, and care coordination is going to be one of the big themes that will come out of the Innovation Center as they redesign their approach to models. And the interesting question is, for some people, and they think a lot about primary care, but as a specialist and working still.
Hi everybody, my name is Ollie. I'm a junior doctor living and working in England, and welcome back to my YouTube channel. Now, as I promised in my recent update video,
Still in an academic medical center, oncologists for some people are their primary care providers in coordination with, as you've been describing, the nursing teams, and you look at what was actually delayed for 2 years, some of the care coordination codes for physicians. So I think that one of the key questions will be, how do you, if their primary problem is oncology, how do you stand up as part of that primary care or that care coordination, as opposed to saying it must be a primary care provider?
Agreed.
wanted to follow up on that last comment actually, and so care coordination and communication among healthcare providers has been noted as a major challenge, especially for oncology patients who often have multiple healthcare providers. So I'm wondering if one of the potential venues for telehealth is actually to use it for sort of a modified tumor board session, but really not focusing on the treatment plan, but really focusing on the overall care of the patient. So I'm wondering if anybody can comment on that as well.
So we've done that actually, because we again have the luxury of not having to worry about reimbursement, but for sort of our new high risk patients in our prostate clinic, we're able to bring in basically do multidisciplinary clinic where we show the images from the MRI, go with pathology. We have the urologist, the radiation oncologist, and medical oncologist there, but we do it within a very fixed time period. So we don't let this sort of go on for hours and hours as it could, and then have the patient that follow up with individual practitioners about very specific sort of detailed medical questions about their specialty. And it's actually worked well, and I think we've all learned from the other specialists. It takes coordination. I think that's something you can do with telehealth maybe a little bit better, because you can sort of get on a folks' calendar in advance and it's sort of locked in, as opposed to come by after seeing the clinic. But I think it's, again, bringing folks together, different specialties works, and I think putting a time limit on it, I think, becomes important, because otherwise in telehealth it can sort of drift sort of endlessly. So we've had a very positive experience with it.
And Dr. Zahn, I see you raising your hand.
So, we have been doing 2 to 3 tumor boards, we call them tumor boards, or multidisciplinary conferences a week for years. So as the pandemic hit, we very quickly converted into telehealth with Zoom. Now, the difference is that when we were in person, we would invite the patient and the family, if they chose to come and attend. We did not do it with Zoom. The Zoom still had all the same specialties, we had radiology, pathology, all the disciplines involved, and we followed exactly the same structure as we had previously. And then at the end, I would then, for example, my patients, I would just discuss them later that day, just as I would in person, and tell them what the tumor board conference discussion was about their case and what the recommendations were. So we just migrated to telehealth, quote unquote, but we didn't charge. There was no billing issues. We didn't charge even in person prior to that. The only charge was the face-to-face visit that I had with that patient, or a telehealth audio or audiovisual conference. I would have that patient afterwards. I think many of my colleagues across the country and community sites are doing exactly the same thing.
If I could add too, there's a model for this in collaborative care, which worked out in mental health, in which perhaps you have a psychiatrist at a central location who's working with providers at multiple clinics who may have some limited training in mental health issues, but for provider communications is making sure that patients are prescribed the right medication, or adhering to the treatment, etc. And this model really needs to be adapted for telehealth and extended to other specialties as well.
So I actually just want to expand a little bit more about the patients and bring the patients back here. So one comment from Dr. Paul Klutz was about, what have we heard from the patients in terms of what has and has not worked? The other piece, I think, is that we heard earlier from Shelley Fultnasso, saying that while patients really enjoyed telemedicine visits, they really wanted to come back to in-person visits. So as we think about the plan going forward, and I think this can pertain to the clinical care and also to the research perspective as well. Who makes the decision? Assuming we don't have the regulation issues, assuming we don't have the the Wi-Fi issues, right? Like all of that has been solved. How and who makes the decision as to which patients and what circumstances somebody should be brought in for a visit, and or somebody should have a telemedicine visit? So Paul, you're still on my camera, so maybe you can start sort of bringing it from the kind of the research perspective.
Sure. So, certainly patient preference should factor into this. But we also have to think of issues of efficiency and utilization of scarce healthcare resources. So I think it's probably a combination of the two. And that's why we need some more research as to what kind of situations and circumstances really do lend themselves to telehealth, and which patients are most likely to benefit. So I think it's going to be a combination of patient characteristics as well as clinical situation that will really be the driving factor, aside from policy issues and reimbursement.
Paula, I know the NCI is going to fund those. What's the anticipated number of centers that will get funded through that new RFA, and when might we expect some of those data to report out?
Sure. So there's funds set aside to fund 3 centers, and the applications were due last Friday. And we think that we'll go to the Board of Scientific Advisors early in 2022. And we really envision these centers as engaging in multiple projects and having multiple collaborators. And each of them is going to have a clinical practice network. As I said, it'll be the laboratory for doing this. We recognize that they'll need to function within a changing healthcare and policy environment, but we think that that's doable. We think these centers can really lead the nation in identifying those kinds of models, which really need to be rolled out and disseminated more widely.
Looks like Dr. Spiegel wanted to say something.
No, I didn't have anything to add.
But Dr. Lennis, you had a really high net promoter score, right, from your patients. So was that across the board? What types of visits were really highly valued? I know it's early data, but really highly valued since you actually have the collection.
So the kind of value, the visits that are highly valued are the more transactional visits, and the ones that are more simple, I would say. I think on the complex, the only exception is complex visits where we're involving multiple family members across the country, I would say. So it's sort of dichotomized into those 2 types of visits where telehealth was really appreciated. I think, though, we're going to see a future where it's always not one or the other. I mean, if you think about our work environments right now, can you imagine a time where we have in-person visits with patients, but telehealth walls where we're able to bring in family members from across the country seamlessly? So, my hope is that these things really merge and that we're able to, like Dr. Jacobson said, meet the patient where they are, and apply the technology that's necessary to give them the best care. And sometimes for some of our patients, having a quick check-in with one of our nursing colleagues or our APPs, avoiding paying for parking and sitting through traffic, it's best to do that via telehealth, and we can do a great job that way. So I think, that's what we're really seeing in the data is that the quick transactional visits are very highly rated, and then the very complex visits that might require many providers or multiple family members are very highly rated.
Dr. Zahn, we'll give you the last word.
Sure. So I just want to remind everybody the expert panel recommendations are in press, and that in fact was one of the areas that we addressed is when in-person visits would be more appropriate than telehealth. But as stated earlier, it's always patient preference. Should dictate whether it's in person or telehealth. But I can speak to personal experience and what I've heard from other folks across the country is that there are times when telehealth is very appropriate. We find that our no-show rate has gone down tremendously because we've offered telehealth visits for follow-up of your medication starts, for example. So we've actually been able to intercede and intervene to be able to reduce toxicities and manage those much more effectively. So that's just an example of a benefit of telehealth ongoing even after the pandemic.
Yeah, without question. I know we're almost at time here, but I expect that we'll uncover some of these, more data from Dr. Jacobson's efforts at the NCI and funding those centers, but also the impact on providers, and which will be a component of that as well, which is really I didn't get a chance to talk about today. So I'd like to just give our keynote, Dr. Kelly, just a moment for a few closing words, since you have most experience with telehealth here and having done it at the VA for so long.
Thanks. I think the experience of the VA hopefully gives hope for long-term utilization of really the facility of using whatever means of communication with the patient wants and are effective. And the barriers that we're talking about are all human-made. They're not inherent in anything that can't be mutated. So I would encourage the regulators and all of you to continue to push this out to your patients. And obviously that is going to be dependent upon the shared interests of colleags and regulators. So I think that the future looks bright, I think, in terms of moving medicine into a different environment where competition is no longer regulated by geography.
Yeah, I agree. Thank you so much for giving us your experiences, the hope also for Dr. Dayhut, in terms of being able to enroll patients on trial using this important mechanism too, without the barriers of licensure and some of the things the rest of us face. So I'd like to thank all of the panelists and my co-chair for a really wonderful session. And I think this is where we give it back over to Dr. Shilsky for a wrap up of this really wonderful first day.
Yeah, thank you very much, Karen and Larissa. What a great session. So this does bring us to the conclusion of day one of our workshop. I want to thank everyone who's been attending for all parts of it. I think the speakers today were terrific, but really the discussions were very rich. And in particular, the discussion you just heard in this last panel that surfaced a number of issues. So to some extent, go back to the comment that Larry Shulman made early in the day about the fragmentary nature of the US healthcare system. And, I think this is a great example of how having medical licensure regulated by each state individually is really potentially, a barrier to patients receiving, adequate care in the most efficient way. So clearly something that needs to be addressed further. Tomorrow, as I mentioned at the beginning, we're going to pivot a little bit.
Thank you very much for your attendance and listening. We will have a break for Maghrib. We'll be back at 7 p.m. So we'll see you after Maghrib prayer, inshallah. Thank you very much for your attendance. Assalamu alaikum. Welcome back to our next presentation. Our next presentation, as you may know, that the robotic telesurgery started initially three decades ago. Once NASA has released their some of their equipments that they utilize in the space, which we call it the robotics, and it has been utilized more efficiently through the medical companies to promote their utilization. The telemedicine include consultative and diagnostic treatment services. And probably the most prominent pioneer of the field are Tom Sheridan and Richard Steva, both contributing significantly to the birth of a new concepts and technologies. Technology-enabled telepresence, which has a great scientific and commercial potential in healthcare. The new field of telemedicine is defined the use of medical information exchange from one site to another via electronic communications for the health and education of the patient or healthcare provider, and for the purpose of improving patient care. The term telehealth usually refers to clinical and non-clinical services such as education, administration, or research. Long-distance telemonitoring and the time cost effectiveness and the higher level of medical care provided are the most important benefits, while in the extreme telemedicine, such as space exploration, it may be the only available form of adequate medical aid. The term telehealth usually refers to clinical and non-clinical services such as education, administration, or research. Furthermore, it can be broken down into three main categories based on the timing and synchrony of the connection. Telemedicine can be online or offline, depending on the technical quality of the communication link. Store and forward telemedicine means there is only one-way communication at a time, and the remote physician evaluates medical information offline and sends it back to the original site and another time. Finally, interactive telepresence provides real-time communication between the two sites, which might be extended with various forms of interactions, allowing for a set of telemedicine services. You can see that there are online and offline. And the offline, you've signed that it's like a telediagnostic, remote treatment planning, tele-follow-up, and pre-referral screening. But in the online, which is a real-time, either it's interactive or it's a remote monitoring. And remote monitoring, this passes through the passive telepresence, the teleconference, but in the interactive telepresence, hands-on telemonitoring and remote surgery. Healthcare in space represent a unique field of medicine requiring extreme technological solutions. Space medicine embraces all the different aspects of healthcare in connection with space exploration. It includes both basic crew selection tests and advanced on-flight surgical support. And based on the medical events recorded by the National Aeronautic and Space Administration, NASA, there have been several dozen medical events and complaints. Proficiency in MIS and laparoscopic surgery requires extreme amounts of practice, and maintenance of skills is only possible with continuing care training. And the idea of telerobotic healthcare in space dates back to early 1970s, proposed in a study for NASA to provide surgical care for astronauts with remote-controlled robots. This is particularly relevant and desirable as a specific high-level medical education flight surgeons might be impossible to achieve. Once in 1982, astronauts almost had to be evacuated on a space shuttle with the symptoms of kidney stones. The US Army has always been interested in telesurgery for the battlefield, and currently the Telemedicine and Advanced Technology Research Center. With the help of mechatronic devices, physicians were first able to affect remote patients with the green telepresence systems in 1991. Simulated surgical experiments in weightlessness have shown that endoscopic procedures provide a real option to perform surgery in confined body cavity, handling body fluids and organs. The US Department of Defense aimed to develop a system, TraumaPod, by 2025 that allows combat surgeons to perform life-saving operations on wounded soldiers from a safe distance. The teleoperated system typically consists of three parts, one or more slave arms and master controller with sensory system providing a feedback to the user. In practice, only a few surgical robots are autonomous or cooperatively controlled. Most systems are entirely remote controlled, i.e. the surgeon is absolutely in charge of motion of the robot. Based on gathered visual information, the surgeon guided the arm by moving controller and closely watching its effect. While the desire to create superior surgical robot push the researchers forward all around the world. Present-day commercial systems are more focused on one key target procedure each. The most well-known commercialized robots are the Da Vinci and the other Zeiss telesurgical system. And while those robots were built with the structure and feature that make them capable of performing distal teleoperation, most commonly they are used for on-site surgery. The market-leading completed teleoperated robot and created roughly around 500 million investment. The system provides high-quality 3D vision with a stereo endoscopic adjustable trimmer filtering and motion scaling. In 1995, the newly founded Intuitive Surgical License Technology from NASA, SRI, and IBM, several universities, as the system was originally intended for cardiovascular beating heart surgery, specific clinical trials were performed in Paris in 1998. Based on the initial experience, a market-ready version of robot had upgraded control and ergonomic features. Once the system was on the market, Intuitive Continuing Perfect, the second generation, was released in 2006. The latest version became available in 2009 with improved full HD camera system, advanced ergonomic features, and most importantly, possibility to use two consoles for assisted surgery. The most successful application of a robot became prostatectomy. Around 90% of all radical prostate removal procedures were performed robotically in USA in 2009, according to Intuitive. The Defense Advanced Research Project Agency, the DRPA of the DoD, initiated the Trauma Code Project in 1994, primarily to enhance battlefield casualty care by developing autonomous and semi-autonomous mobile platform through the integration of telerobotic and robotic medical systems. Extending the framework of the program, robots developed with the help of the DRPA, which have already been tested under the extreme circumstances. Several prototype systems never reached commercialization, although they were created with the aim of facilitating telesurgery in space. RAMs consist of two arms equipped with tip force sensors providing hepatic feedback to the operator. It used the concept of telesurgery for control. However, the operator sat right next to the slave arm. The doctor and scientists at Biorobotics, University of Washington, have developed a portable surgical robot for spacecraft within 22 kg overall mass. Can easily be assembled even by non-engineer, and its communication lights have been designed for long-distance remote control. The SRI started to develop M7 robots in 1998. The system is lightweight and able to exert significant forces compared with its size. It is equipped with 2.7 DOF manipulators. It can easily be assembled, and the system participated in multiple field tests and intercontinental trials, and now several units are being built for large-scale clinical trials. The robot control bore was designed to operate under extremely different atmospheric conditions. The software of M7 was later updated to better suit the requirements of teleoperation. The German Aerospace Center Institute of Robotics and also had already built several generations. They have also taken part in the many telerobotic space experiments in the past decades. As you can see here, that M7 robot developed by SRI international M7 on board a NASA parabolic flight where the DC-9 aircraft flew along parabolic curves to create 20 and 25 of weightlessness on board. Surgical knot tying procedure were tested on phantoms to evaluate the human performance. As you can see here also, the link bird operation, the surgeon, the council of ZESUS, and also you can see in the other side, in the B side, that the patient and the slave robotic arms were in Strasbourg in France in 1998. The ZEUS robot proved to be a solid platform to test different surgical scenario. After 6 foreseen cholecystectomies, the first transatlantic human procedure was done in 2001. A 68-year-old female with history of symptomatic cholecystitis underwent an eventual cholecystectomy procedure. Based on previous research, it was estimated that the time delay between the master council and the robot needs to be less than 330 milliseconds to perform the operation safely, while above 700 milliseconds, the operator may have a real difficulties controlling the disease. In Canada, the world's first regular telerobotic surgical service network was built and managed routinely between the Center of Minimal Invasive Surgery. The average latency recorded was about 150 milliseconds using commercial high-speed internet link over virtual private network. A high-quality dedicated asynchronous transfer mode, ATM, fiber optic links was provided by France Telecom, which provided 155 millisecond communication lag time during that experiment. Intercontinental surgery was latency between 135 and 140 milliseconds. The network was later extended to include more centers in Canada. The C-Star group in London, Ontario, evaluated the satellite collection versus ground communication to Halifax while performing internal memory RT dissection and 15 pigs, and the average latency was 55 milliseconds over ground communication channel and around 600 milliseconds via satellite collection. A remotely controlled robot actuated catheter guiding device was used in Milan 2006 to automatically perform heart ablation, initiated and supervised by a group of professionals from Boston, MA. NASA conducted several experiments to examine the effect of latency and human performance in the case of telesurgery and telemonitoring. The NASA Extreme Environment Mission Operations, NEMO, always take place in Florida, and the world's only permanent undersea laboratory, Aquarius. The 14 NEMO projects have been organized since 2001, and 3 of which were focused on telemedicine. A special buyout provides connection for electricity, life support, and communication, and shore-based control center support the habitat with maximum crew of 6 people. The 4 crew members had to perform 5 test procedures, ultrasonic examination of abdominal organs and structure. The ESOP was controlled from the Canadian, and the signal delay was tuned between 100 milliseconds and 2 seconds to observe the effect of latency. Based on a set of measurements, a greater effectiveness of teleoperation was shown compared with telemonitoring. However, the latter took less time to complete. A microwave satellite connection was used. The time delay went up 3 seconds to mimic moon-earth communication links. Based on a set of measurements, a greater effectiveness of teleoperation was shown compared with telemonitoring. However, the latter took less time to complete. In addition, each of 4 astronauts had to train for at least 2 hours with a wielded in vivo robots designed at University of Nebraska. Surgical experiments were first reported by a Russian Kozamond, and the first survival procedure was performed in STS-90, and the plane performed 250 parabolic curves, providing up to 25 seconds of weightlessness every time. NASA carried out the first zero-gravity robotic surgery experiment in late September 2007. The experiment showed that a human can better adapt to extreme environment. However, advanced robotic solutions perform comparably. As you can see here, the Raven robot developed at the University of Washington, the Master Council of Raven Robot. The primary difficulty with teleoperation over a large distance or low quality network infrastructure is the communication lag time. The continuous development of the terrestrial internet backbone network has resulted in a significant reduction of typical latencies. Using commercial services, delay might be around 85 milliseconds across the USA. Accurate and synchronized sensory feedback is essential to ensure reliable and effective telesurgical treatment. Telerobotic experiment in 2009 showed 112 millisecond latency of various connections within USA and 305 milliseconds for intercontinental connections. Geosynchronous satellites provide higher latency due to their 36,000 kilometer altitude. Round trip latency is 540 up to 700 milliseconds typically. Understandably, designated military satellite can provide a lot faster communication channel. A minimum latency per satellite hop is expected to be 4.37.8 millisecond one way. Despite the recent improvement in ground-based transmission, satellite communication has the potential to overcome wired lines primarily in speed. Satellite-based internet connection can use a fleet or a low-medium Earth orbit satellite where typical round-trip delay are 40 milliseconds, but bandwidth is very limited. The planned Mars orbit is between 56 and 389 million kilometers from Earth, which means 6.5 up to 44-minute delay in transmission. Most humans are capable of adapting to sensory feedback latency up to 500 milliseconds. Beyond Earth orbit, radio microwave frequency signals propagate at almost the speed of light. However, already in the range of long distance manned space missions, several minutes of latency can be expected. While advanced internet speed communication enables telesurgery all over the Earth, serious technological problems arise in the case of long-haul space exploration missions. Depending on the physical distance between the spacecraft and the ground control center, different telepresence technologies may provide the best performance. Currently, it seems inevitable to have flight surgeon on board the spacecraft, as robots do not have enough autonomy to adapt any unforeseeable event. Mainly within a range of 380,000 kilometers, semi-real-time telesurgery techniques can be used to provide medical support in the case of emergency. With robot-assisted surgery, shared control approach should be followed, integrating high-fidelity automated functions into the robot to extend the capabilities of the human surgeon through the image processing and force sensing. This concept could be most beneficial for long duration on a robot in orbit mission, primarily on board the International Space Station. Flying further from Earth and reaching the limits of semi-real-time communication procedures should be performed by the flight surgeon under detailed telemonitoring guidance of master surgeons on the ground. Telemonitoring requires exchange of still images, motion video, video conferences, electronic chat, and data file transfer. Presently, there is no option rather than immediate evacuation of the affected astronaut, which poses a larger health risk and huge cost. Telemonitoring may extend boundaries of telepresence, as it can still be effective with 50 up to 70 second delay. On the other hand, defining virtual boundaries of the robot may reduce the risk of accidents. The built-in semi-autonomous functions of the surgical robot will play a major role in improving the overall quality of surgery, and astronauts should also benefit from the advanced imaging technologies. As you can see here that the communication lag time, the distance from Earth is quite variable. So if you go for long distance, middle range, near Earth, telesurgery, telemonitoring, all these should be considered. General concept for telemedicine support for long duration space flight. The fundamental goal of telehealth support is to provide maximum level of available medical care to astronauts during mission. I think that was our last slide. Any question from the audience? أي سؤال يا أخوان؟ I think we have to move to the next presentation, our last presentation for today. A telesurgery robot based on 5G tactile internet. Namely, doctor doesn't touch a patient directly during surgery performed by a robot through ultra-reliable, low-latency communication. Once the incision position is determined, the mechanical arm equipped with the camera and other surgical tools perform the action of cutting, stopping bleeding, and suture. Moreover, telesurgery robot is well-deserved revolutionary surgery tool used in minimally invasive surgeries worldwide. Telesurgery robot is a complex device that integrates multiple modern high technologies. And using telesurgery robot, a surgeon can operate the machinery and perform surgery away from the operating table. The console that the doctor uses represents a human machine interactive system interface and composed of tactile device involving and the surgery robot is equipped with 3D camera, microphone, multiple forces, and tactile sensors. Moreover, the console and the robot are connected with a reliable high-speed communication network. Tactile sensation refers to a feeling produced when a human skin, hair, and other body parts contact with the external objects. The type of tactile perception include force sense, pressure sense, texture sense, etc. The 5G network can support the enormous data flow and can deliver the network service by the cost. far below the present network do. And the type of tactile perception includes force sense, pressure sense, texture sense, etc. If the problem of the reaction time delay of each sensation during the remote interaction is solved, a human can achieve the real-time interaction with the remote machine based on their perception. In the normal case, the human reaction time to auditory sensation, visual sensation, and tactile sensation was 100 millisecond, 40 millisecond, 1 millisecond respectively. If the problem of the reaction time delay of each sensation during the remote interaction is solved, human can achieve the real-time interaction with remote machinery based on their perception. Thus, human can see, hear, touch, and perceive distant things. For instance, if the user eye perceive movement, but the corresponding voice lags and the corresponding tactile information is not changed, the delay in the perceptual information transfer will lead to asynchronous information of the user perception and make the user get the bad network interactive experience. Therefore, the response should be accelerated. The network transmission delay should be minimized. The interaction between the master control terminal and the control terminal through the tactile internet and the end-to-end data communication should consider the delay. Moreover, ultra-high reliability of data communication is a pre-requirement to met by the tactile internet. Telecommunication, the communication requirements of robot of multimodal sensing, data transmission through the 5G tactile internet and the telesurgery as directly representing the characteristics of the telesurgery. Among the multimodal data mainly refer to various physiological indicators of patients and data collected by surgical robots. The patient's physiological index data is collected by various sensors deployed in various parts of the patient body. Some silent objects detection methods may be used to pre-process the image data collected after the data acquisition under the premises of the meeting and of the communication requirement, and the cloud integration methods is adopted to promptly present the data to the doctor. The surgery robot is equipped with a tactile sensor and display the tactile feedback signals by the graphics. The mechanical arm of the surgery robot is equipped with a tactile sensor and the tactile feedback stimulate the true physical strength directly or indirectly to facilitate the remote diagnosis and operation. The existing designs provide the forced tactile interaction during the virtual surgery using the magnetic field of electromagnetic coil array and a trial manufacture of the surgical instruments with a specific magnetic. The existing design provides the force of tactile interaction. During interaction, acquisition of high precision force feedback requires a real-time accuracy control of the links involving the tactile device, the transmission and communication network, cognitive engine, and cyber physical unit. The coil array generates electromagnetic field in the stereoscopic space by controlling the excitation current of electromagnetic coil. Also, different excitation current can generate the magnetic field of varying intensity. The tactile device directly influences the force, tactile perception of the action point of surgical instrument, while the quality of transmission and communication network determine the accuracy of mobility of operation of the surgical instruments. When the surgical instruments magnetic stimulate the operation and the magnetic field environment, the force tactile feedback will be generated. Meanwhile, electromagnetic field distribution can be adjusted by controlling the position posture of electromagnetic coil to change the range and electromagnetic action and enhance the perception of a force tactile interaction. In the virtual reality, the required electromagnetic field with a specific space distribution and intensity is calculated by the model of magnetic elevation force feedback based on the required feedback force. Finally, the control information of electromagnetic coil array is output to achieve the human-machine interaction effect using the magnetic deviation force tactile feedback. As you can see here that there is a distance intercontinental connection between different continents. And you can see here that there are different places and there is a cloud and there is the edge also. Then you will be able to distribute through the 5G internet your connection everywhere. So the human-machine interaction optimization and the control terminal various sensors are deployed to comprehensively measure the physiological status of the patient during the surgery and operation accuracy of the medical instruments. And the human reaction time to the tactile sensation is about 1 millisecond, which require the data processing and transmission of tactile internet application with time consumption as much as possible. In the master control terminal, the original operation data of the doctor should be processed in a real time after collection. The combination with the various stages of tactile interaction mentioned in section 2, the following methods can be adopted to reduce the end-to-end interaction delay. The master control terminal gets the physiological information of the patient, position of the mechanical arm, contextual information, and tactile the pressure information by deploying various sensors. Moreover, it also analyzes the current status of the patient using the combination of multiple groups of characteristics information. In practical telesurgery application, 5G tactile network requires the master control terminal to have fast processing of the original operating information of a doctor and the generation of ultimate control command to the control terminal. However, such requirement demand an extremely complicated operation and certainly leads to an increase of processing time in the traditional model. Edge cloud integration make use of limited resources span everything from a real-time video to a human-machine interaction services. Consequently, a network resources and communication optimization need to be considered. Recently, the study input forwards in a new view. The work models of trade-off between resource cost and quality experience as an economic resource utilization. From the perspective of network resource, a large volume video data economic modeling benefits to solve the contradiction between ultra-low delay and ultra-high bandwidth for edge cloud integration. We test the tactile acquisition delay in robot, the simulation prototype of robot tactile flexible thin film pressure sensors in 1M. And the tactile signal acquisition delay changes periodically with the experiment round, which varies from up to 4 milliseconds up to 5 milliseconds. Besides, when a stable transmission link is established, tactile transmission delay from a robot to cloud will be stable in about 80 milliseconds, which can maximize and guarantee the operation of telesurgery. Network slice refers to connection service based on various customized communication requirements. On the other hand, SDN provides the decoupling of control layer and data layer to make a network control programmable. The based on programmable physical infrastructure, the programming function of the core network and run in 5G network can be realized by these technologies. The 5G network distributes different network slices for different applications. The application uses different communication bandwidths to ensure non-interference communication of each application. You can see here that the tactile acquisition delay in robot and the tactile interaction delay from robot to cloud, there will be a difference, and there is a delay in the tactile interaction round. The HA of artificial intelligence, the reaction time to tactile interaction is 1 millisecond in consideration of data communication round trip. To solve this problem, the tactile interactive mechanism that combine the predicted and actual doctor behavior is designed. In case of overtime, the surgery robot should have the ability to predict the next behavior of the doctor and operate accordingly to avoid operation jitter. Different surgeons have different behavioral habits of surgery and operation, and corresponding operation data are different. Even if the data correspond to the same application, since it cannot either be used to predict the behavior of another doctor. The ultra-high reliability, the overtime transmission of information have greatly increased the delay of interaction and influence the real-time performance of interaction. Moreover, the current wireless network link with a network interruption rate is about 3% and considered as a good link. In the future telesurgery systems, we will not only need to upgrade the hardware infrastructure to enhance the reliability of a link, but also design a better communication strategy to provide a satisfactory communication reliability for the application. For instance, assume that during the establishment of communication connection, 3 independent end-to-end communication links are built simultaneously. In the actual network, the entirely independent communication links may not be built due to the existence of some key nodes. Moreover, the reliability of a single node should also be improved as much as possible in the case of unavoidable key nodes. An AI-enabled surgery robot, the patient have higher and higher requirements for the accuracy and the cost effectiveness of the treatment performed with the intelligent surgery robot. With the aim to meet these demands, these service providers are facing new challenges such as acquisition of multimodal sensing data. The telesurgery system has a large number of heterogeneous access devices such as multimodal sensors. And nevertheless, in fact, the surgery data obtained from different objects, devices, and environment are very different regarding the surgical operation process, pathologic expression mode, data marker scheme, physiological signals. On the other hand, the result of pathologic data analysis are closely related to the personal health. When the remote medical system communicates through a public network, it is confronted with the various security and privacy issues. This effectively reduces the latency. And this effectively reduces the latency and provide more communication resources for the user in the emergency conditions, and also ensure reliable and latest patient information to the doctor. This engine collects the external data from the cognitive application, which include physical signals and user behavior. Moreover, the data cognitive engine collects the internal data, including the network type, services data flow, communication quality. For instance, considering the mobility of single user through cognition to the user behavior, edge computing environment is capable of realizing the real-time surface switching. For instance, cognitive health services surveillance utilize the static basic information about users and disease sick level information updated by the user in real time, and then combine the dynamic network resource information in the edge computing environment. Moreover, it can receive the analysis result of the data cognitive engine and realize the real-time dynamic resource allocation and optimization. Moreover, it utilizes the cloud platform and intelligent algorithm to form a cognitive engine with resource optimization and energy saving. As you can see here, that the ECC-based smart healthcare system in different locations. The external data is referred to and analyzed by the data cognitive engine. Meanwhile, it guides the resource cognitive engine to make an optimal distribution of the resources. The real-time data flow and the dynamic network environment contains various resources, including the edge cloud computing resources, and the internal data dynamically guides the network resource distribution and continually. So the machine learning, deep learning, cognitive computing, all of these are quite important in the ECC-based smart healthcare system. The machine learning is a quite important subject, and the common machine learning methods include regression analysis, decision tree, Bayesian network correlation analysis, clustering analysis, and dimension reduction. Also, artificial neural network. All of these will be significant tasks. The data level directly influences the accuracy of learning algorithm. At the same time, deep learning has a good effect in the term of visualization, natural language processing, and multimedia data processing. Cognitive computing carries out data cognition for the information relevant to the user's disease, the resource cognition with respect to the information about network and the computing resource environment of the user. I think that was our last slide. Any question from the audience? I think we are done for tonight. There are no questions. We'll close the ceremony for today. And I guess we will meet tomorrow. Same time, 2 p.m.